Good morning, everyone. So we are starting our third class, and today we're gonna look at the last chapter of the book, so chapter 8, and we're gonna look at two um, conditions, so nasopharyngeal cancer and esophageal cancer. So let's start first with nasopharyngeal cancer. So we'll start with short medical animation video just to get us into understanding of what nasopharyngeal carcinoma stands for. And I'll post the address for in chat area for the medical animation. And for the additional one that we're going to look at later. Just give me a sec. There we go. Let's first look at a medical animation of nasopharyngeal carcinoma.
Topic is nasopharyngeal carcinoma. Nasopharyngeal carcinoma, also known as NPC, is a rare tumor of the head and neck which originates in the nasopharynx. The nasopharynx is located at the very back of the nose near the eustachian tubes. Nasopharyngeal carcinoma is rare in the United States. It occurs much more frequently in other parts of the world, specifically Southeast Asia. Nasopharyngeal carcinoma is difficult to detect early. That's probably because the nasopharynx isn't easy to examine, and symptoms of nasopharyngeal carcinoma mimic those of other more common conditions. Symptoms. Some symptoms of NPC are enlarged lymph node in the neck, bleeding from the nose or mouth, difficulty popping ears. This is due to the close proximity of the tumor to the eustachian tube, resulting in blockage and accumulation of fluid in the middle ear. Difficulty breathing through the nose. Cause. Cancer begins when one or more genetic mutations cause normal cells to grow out of control, invade surrounding structures, and eventually spread or metastasize to other parts of the body. In nasopharyngeal carcinomas, this process begins in the squamous cells that line the surface of the nasopharynx. Exactly what causes the gene mutations that lead to nasopharyngeal carcinoma isn't known. Diagnosis and treatment. Some diagnoses that a doctor may carry out are exam using a camera to see inside your nasopharynx, physical exam, test to remove a sample of suspicious cells. Once the diagnosis is confirmed, your doctor orders other tests to determine the extent or stage of the cancer, such as imaging tests. Imaging tests may include computerized tomography or CT, magnetic resonance imaging or MRI, positron emission tomography or PET, X-ray. Treatments for NPC are chemotherapy, radiation, surgery. If you're concerned about your risk of nasopharyngeal carcinoma, you may consider avoiding habits that have been associated with the disease. For instance, you may choose to cut back on the number of salt-cured foods you eat, or avoid these foods altogether. Thank you for watching our video. Please do not forget.
Okay, so that was the short video allowing us to look into description, assessment, diagnosis, and treatment from Western point of view of nasopharyngeal carcinoma or cancer itself. So from the TCM point of view, it's a malignant tumor. It's more prevalent in Asia, now more so also here in North America because of immigration as well. TCM does not have distinctive name for this form of cancer. So it goes under basically several names depending on presentation. So for example, nosebleeds, as we saw from video, could be one. So BNU, Zhento Tong, headache, right? Shangshiju, upper body stone abscess, often when there's swollen lymph nodes and difficulties swallowing. nasal polyp, Berger, Sjörom, right? Cervical lymph nodes, so Schurcher, double vision. So it's interesting that even in modern Chinese medicine, so-called integrated Chinese medicine, as we sometimes call TCM, because it's integrated with Western medicine, especially in oncology, there is still not defined term for nasopharyngeal cancer. So we can hope that maybe in the future oncological books, they may have actually opinion and TCM terminology for this cancer. So etiologically, or actually clinical manifestation wise, we see usually problems with breathing through the nose, problems with a bit of a balance, discharge of pus or blood from nose, spreading the lymph nodes, creating difficulty in swallowing, swollen lymph nodes in the neck. And etiologically, TCM looks this through few etiological or pathophysiological themes. One of them is exuberance and stagnation of heat toxins, mostly affecting the lung and upper jiao, congealing and stagnation of qi and blood that is triggered from liver and gallbladder, but it's manifesting from middle jiao into upper jiao, binding of the phlegm heat. Again, combination of liver and spleen and not interacting. So middle jiao pathology that manifests in upper jiao. So let's look at certain treatments here. So we're going to look first towards herbal pharmacotherapy. So first pattern we're going to look is congealing and stagnation of the qi and blood due to liver qi depression invading the lungs. So in 5-element pathophysiology, this is what we call grandchild insulting the grandparent. So what we mean is the metal or lungs or respiratory system is the one that is controlling and overseeing the wood liver hepatic system. And so in this case, the hepatic system, due to change in blood chemistry and change in a qi, basically the liver's acidifying blood to lung, so insulting, basically backflowing, and that of course creates all kind of problems for respiratory system in purifying blood, removing CO2, and of course diffusing O2 into the blood. Often that's not always the case, so then we have increase in carbonic acid in the blood, in the lungs, leading to things like bloody nasal discharge, distension, oppression of inner ear. So sensory orifices may be affected in the head and neck, headaches, dizziness, irritability, chest oppression and pain, constipation. So it's mostly upper jiao, but we see also systemic symptoms spreading in the middle and the lower jiao. When we typically look at tongue, we may have purple kind of tinge or purple sublingual veins are maybe distended. Pulse is generally wiry and rough or irregular. So treatment principle is to reset the liver chemistry. So dredge the liver, relieve liver qi depression, disperse the swelling in the upper jiao, and dissipates the binding. So basically any growth. So prescription here is augmented free wonder powder, or Jiawei, Xiaoyaosan, Jiejian, with modifications. So what they did is they took Uplerum and Dangwei, or Easy Wonder, sometimes translated in English, Xiaoyaosan, and they augmented and they added some other modification to this harmonizing formula to make it more interventional formula. Right. So so this resets the liver physiology, which allows the hepatic liver to purify the blood, which in turn allows the lung to maintain alkaline nature of the blood, 7.2 to 7.4. Some authors say 7.6 maybe. So this denies usually tumors and cancers existence because of alkaline nature of the blood. So we see, usually lessening and reducements of the growth and multiplication of the cancer cells. So the next one we're looking is accumulated heat in the lungs, scorching body fluids to form the phlegm. So we see again a change from alkalinity, from base-like chemistry of the tissue to acid-like. And so this creates inflammatory heat in a tissue, especially in the pleural cavity, which then thickens the fluids that lubricate the lungs outside and also from inside. And so this usually thickens from dampness into the phlegm, creating compression in and around the respiratory organ and the surrounding tissue, namely in the head and the neck. So bloody nasal discharge, we have nasal congestion, blocked nose, coughing is productive with the phlegm, chest oppression, shortness of breath, heaviness in the head, sometimes in the chest, palpitations, nausea, poor appetite, snoring at night. Tongue is often swollen with thick, greasy or white coating, pulses wiry and rapid. So treatment principle here is to clear the inflammatory heat in the lungs, transform or thin turbidity or phlegm down into dampness, and then deal with it through lymphatic drainage. And at the same time, fortifying spleen to basically prevent thickening of the fluids into dampness and phlegm. So the formula we use here is Qing Qi Hua Tang Wan Jie Jian, right? Pill for clearing the qi and thinning or transforming phlegm. So again, this is interventional formula, thinning down the phlegm, secondary tonifying spleen, and then once the phlegm is thinned through diuresis, urination and sweating, getting rid of it through lymphatic system and urinary system. So this usually decreases the growth and the volume of the blockage. So the third pattern we're looking is pathogenic wind heat toxins accumulating in the ZANF organs and blocking particularly the lung network vessels. So we have latent heat that remains after respiratory conditions, lower immune response from lung wei qi and overall zheng qi. And so patient presents with headache, dizziness, blurred vision, facial paralysis in severe cases. So it almost looks like they had a stroke. Nasal congestion, nosebleeds, bitter taste in the mouth, irritability, insomnia, coughing, productive thick cough. So tongue body is often a bit on a darker kind of side, darker red side with yellow coating, pulses wiry and rapid. So treatment principle is again to reset blood chemistry, so to deny metastasis, right? Extinguishing the wind, so basically clearing the pathogens, wind and the heat from the lungs, and hopefully resulting in lessening of the lesion. So the formula we use here is antelope horn and Oncaria, the Coxsackie modification. So that's a Ling Jiao Gou Teng Tang Jie Jian. So this formula is used in some modifications also for seizures. And so here is augmented to deal with mopping up remains of the latent pathogen and changing the chemistry of the blood back to normal. So the next pattern that we're looking is depletion of qi in blood due to debilitation of the vital qi, of the zheng qi. So often we have this in someone who's either older or maybe mid-age. So often person had debilitating conditions through their life. So they have overall zheng qi weakened over the probably several years, if not decade. And eventually it depletes the qi in blood to the point that it allows for malignancy to present itself here. And so the patient presents with dull gray facial complexion, lack of strength in the limbs, cold limbs. They're very deconditioned. Microcirculation is not good. Aching in different parts of the body, low back, bones, knees. When we look at tongue, it's dull, it's pale, maybe with a white coating, maybe no coating. Pulse is usually deep and dirty, sometimes weak. So we want to supplement qi and nourish the blood. So boost the motility of the qi and boost or normalize chemistry of the blood, right? So Ren Shen Yang Rong Tang Jie Jian, ginseng decoction for nourishing the nutritive qi, the yin qi, with modifications used here. So we want to again increase a bit of a motility of the blood, but also maintain proper nutrient chemistry of the blood, right? So and the pH of the blood. From the acupuncture point of view, we have a central kind of protocol, but it could be adapted depending to syndrome. So we have main points, which are combination of Bakshu points and some generally distal points. So main points are like bladder 13, bladder 15, triple burner 17, large intestine 20, triple bladder 21, small intestine 19. And then we have auxiliary, so secondary points, so lung 7, PC6, large intestine 4, stomach 36. So let's look at moxibustion. So moxibustion can be used as well for certain syndromes. So we have governing vessel or due vessel 22, 23, bladder 7, due or governing vessels 20. And then, of course, lots of these points are on the head and around the neck. We have Taiyang, extra point, stomach 2, gallbladder 14. So some of these points we can use the indirect moxa on a slice of garlic. Others can be used with the moxa pole or moxa stick. Ear acupuncture can be used as well with seeds or tack needles. So upper and lower lungs, heart, large intestine, adrenal gland, endocrine, nose, and throat. And these can be changed according to authors every few days. I would say in some patients, you can even leave it longer, especially if they're tack needles, up to 7 days. So here they say use alternate ears. I usually prefer to use both ears. I find that if patient can tolerate, it gives you stronger treatment. So that's sort of a direct treatment that we would be maybe involved. And now in the West, that's less likely because patients often go to see oncologists, they get staged and diagnosed. At what stage of nasopharyngeal cancer they are. There's tests from lab to imaging and so on. TCM, of course, can be used in a secondary role to treat common complication nasopharyngeal cancer and to treat patients concurrently as they're receiving things like surgery or post-surgically or post-radiation, during radiation or during chemo or post-chemotherapy. So this is mostly the role that we have in the West. So here we see a TCM treatment of common complications such as headache, burning pain in the throat, low-grade fever, high fever, and what they use is so-called hospital oncological formulas. So proprietary formulas that physicians create for things like nausea, poor appetite, scrofula, and phlegm nodes. And so they usually modifications of known formula. The physicians over time change that and then they use it. So as we mentioned, in the West, we typically are in supporting role, while our colleagues in China may be in a front kind of role, treating from get-go development. But of course, they have access to Western imaging and labs. So they're in much better clinical positions to not only discover it, but follow up the clinical unraveling of the patients as they use TCM treatments, because they use, again, Western imaging and the lab tests to keep close eye on how the person is advancing in a treatment. So when we look at surgery and subsequently post-operative period, acupuncture can be used with good success. So here we have tinnitus and poor hearing, which may result in either complication of surgery or just debilitating state of the patient. So etiologically can be caused by an effulgent liver and gallbladder fire that moves upward, leads to qi obstruction, Shaoyang channel. So that's triple warmer and gallbladder, resulting usually in binding of phlegm and heat, and that blocks the generally hearing. We see this also as a otitis media, or often inflammation and of the middle ear, sometimes inner ear. So treatment principle is to clear a dry liver fire, dispel the phlegm, and free the orifices. So we have, again, local points and some distal points. So here we have points on Shaoyang mostly, right? So we have gallbladder 42, we have triple burner 3, gallbladder 2, triple burner 21, triple burner 17. And of course, we can add certain points. If there's a more liver fire surging upward, we can add liver to the fire point in the wound meridian. For depression and binding and heaviness of phlegm and heat, we can add PC8 and stomach 40, right? So for example, using local points like gallbladder 2, triple burner 2117, opens the pathway of microcirculation around the ear. Again, combining triple bladder 17 and 3 can sort of open flow better toward the ear, specifically middle ear. Combining again gallbladder 42 and gallbladder 2 basically changes the tissue chemistry and allows the qi and blood to infiltrate the space easier. Applying like dispersing reducing method on liver 2, so spring point on liver can have strong anti-inflammatory actions. PC8 and stomach 40 can thin the phlegm and allow anti-inflammatory actions. So as we can see, acupuncture generally should be done in a block of 10 treatments every day if possible. And we see usually post-surgically good results. Next one that we're looking at is blocked nose due to lung qi deficiency. So lung qi is often suppressed, and then post-surgically there maybe respiratory functions are not at pair, so they're not as 100% recovered. So we usually supplement and augment lung qi, dissipate pathogenic factors, and open the orifices. So combination of bladder 13 and lung 9, source points, right, and backshoe points, supplements overall lung qi and augments passage and motility in and around pleural cavity. Local points like large intestine 20 tend to open up the more nasal passage. Large intestine 4 here opens up the head and neck. Blocked nose due to basically liver qi stagnation, liver blood stasis. So we focus on invigorating liver blood, transforming liver blood stasis, and dispelling any pathogenic factors to open and maintain open orifices, particularly the nasal cavity. So we have a combination of the source points, so liver 3, and then we have CV17 as well to open and move the qi downward. Liver 3 can be also combined with Shui Hai spleen 10 to transform blood stasis and change blood chemistry toward alkaline. Large intestine 20 can open again nasal passage. Large intestine 4 can open orifices around face and the neck. Ear acupuncture, of course, can be used as well in between the treatments to add to depth of the treatment protocol. So inner nose, lung, throat, endocrine, and adrenal glands. Again, could be done either if you have a few days or a week with either seeds or needles. I suggest needles if patients can tolerate. They usually work better. Radiotherapy is another modality to radiation, either targeted from externally or internally. That could be a treatment options that's usually used in Western medicine. So naturally, the TCM here is used to reduce side effects of radiotherapy. So, for example, damage to lung and stomachian is another one because of toxicity. So, person is dehydrated. So, treatment principle is to moisten the lung, clear the heat, nourish stomach, and benefit the throat. So, again, we have one of those hospital proprietary formula, which is a combination of several formulas. Rehmannia 6, Lilly D11, and a couple others. Damp heat obstructing middle burner. So we have dry mouth with bitter taste, nausea, vomiting, poor appetite, reduced food intake. So of course, this becomes the issue because if damp heat is obstructing middle burner, then person not only cannot digest, but it cannot absorb food. So this is actually slowing down recovery, right? And at some point, patients may need to stop actually radiotherapy. So this is where Chinese medicine can assist and decompress and clear the heat and dampness from middle jaw and boost the spleen and stomach and digestion. So another proprietary formula which contains Baohe-1 and a couple others are here prescribed. Lung and kidney yin deficiency. So tidal fever, night sweating, 5 palms sweating, so chest, palms and feet, dizziness, blurred vision, hot flashes. These are all common toxicity-driven effects of usually radiotherapy after 5 or 6 sessions the patients start exhibiting. So treatment principle is to boost and enrich the liver and kidney yin, and also generate and maintain the proper blood chemistry. So Yiguan Jian, or sometimes Ba Wei D11, is used combined with some other herbs here that we see it. Management of sequelae after radiotherapy. So patients again may have issues with difficulty in opening the mouth or radiation damage to bone marrow. So again, different formulas may be prescribed to reset blood chemistry, delivery of the blood in muscles or bone marrow. So Bajingtang and variations may be used. So average survival for nasopharyngeal cancer is slightly less than a year because it's often discovered late. Around 35% may be surviving longer, 5 years. TCM can significantly improve quality of life and efficiency of Western medicine. Radiotherapy, as we mentioned, is usually first choice. Chemo follows, of course, after surgery itself. Problem with chemotherapy and radiotherapy is that they damage the original qi, right? So yuan qi. So sometimes focus is on rebuilding the original yuan qi, rest, low aerobic exercise, nutritional therapy, and so on. So in nutritional therapy, for example, eating fresh vegetables, and for patients with reduced appetite, maybe eating well-cooked meals like soups, stews, and congis. Qigong therapy can help as well. And usually patients should be under supervision of someone who's experienced TCM practitioner in Qigong therapy, where various forms of self-care and Qigong therapy can augment and improve the recovery and overall quality of life. So this would be our review of the current treatment of nasopharyngeal cancer. So we're going to look now into a presentation of that is done through World Head and Neck Cancer Awareness Day, where they looked at overall treatment of nasopharyngeal carcinoma. Okay, so I already posted this link, so let's have a look at this presentation.
Good morning, everyone. I hope everybody can hear me. Welcome to the second in a series of public webinars delivered by the SingHealth UK NUS Head and Neck Center. Today's topic will be nasopharyngeal carcinoma, or the nose cancer, also known as the hidden threat. We are lucky to have a few specialists with us today who will be speaking to us about three separate topics. First one will be signs and symptoms of nasopharyngeal cancer, followed by treatment for nasopharyngeal cancer, and finally, surgery for nasopharyngeal cancer. To begin with, we'll have Dr. Constance Teo, the Head and Senior Consultant from the SingHealth UK NUS Head and Neck Center, and the Senior Consultant in Otorhinolaryngology, give an opening address. Dr. Constance, please go ahead. Dr. Constance, I think you are muted, please.
Apologies for that. Morning, everyone. Yeah, so first and foremost, I'd like to welcome all of you to this webinar on behalf of the team from the SingHealth Duke NUS Head and Neck Center. Why are we talking about nasopharyngeal carcinoma? Because it is actually the commonest head and neck cancer in Singapore, and the symptoms are often very insidious. And we hope that in today's webinar, we can, educate some of you so that we can actually pick all this up earlier and it translates to better outcome for our patients. Very often, all the symptoms are very similar to what you have in a cough and cold, but not all cough and cold are cancer either. So we don't want all of you to panic, but we hope that, if there's anything you'd like to clarify with us today, we'll be happy to answer in the Q&A. So we have a very nice team today from the experts from Changi General Hospital, from National Cancer Center, and from Singapore General Hospital. So I won't delay anymore, and I'll pass the session now over to the team. Thank you very much. Yeah.
Thank you, Dr. Teo. So the first speaker today will be Dr. Leonard Tan, who's a consultant at Changi General Hospital, Department of Otorhinolaryngology. He'll be talking to us about signs and symptoms of nasopharyngeal carcinoma. If you all have any questions, please feel free to type them up into the Q&A feature of Zoom. Do not use the chat function because it will be difficult for us to track them there. Use the Q&A session again, and we'll attempt to address as many of the questions as we can at the end of today's presentations. Dr. Leonard, please go ahead.
Okay, thank you, Simon. Let me just share my screen. Sorry, can I trouble the organizers to stop sharing the screen first?
If you have an hour this week, you can learn 100 songs on the piano by learning just 4 chords. These.
Okay, so I hope everyone can see my screen. My name is Leonard, and today I'll be talking about the signs and symptoms of nasopharyngeal carcinoma. So this is the breakdown or the scope of my talk. I'll be giving everyone a very brief introduction, and then I will go on to the meat of the presentation, which is the signs and symptoms of nasopharyngeal carcinoma. And then I will talk briefly about the diagnosis and management, as most of this will be covered by my 2 other colleagues in the subsequent 2 talks. And then just 2 very short case examples to illustrate some of the points that I've mentioned in my presentation. So I think the nasopharynx is an area that has garnered a lot of attention recently, and that is because we have been doing a lot of PCR swabs because of COVID. And what exactly is a nasopharynx? I think we need to cover this before we talk about nasopharyngeal carcinoma. And the nasopharynx is essentially an area that's actually within this circle on the pictorial diagram on the right. It's actually behind the nasal cavity, and it's sitting above the soft palate as well. And this actually directly communicates with the throat, which is also labeled in this diagram known as the oropharynx. It has also connections to the ear, and this is actually connected to the ear via a tube that's actually located within the region of the nasopharynx called the eustachian tube. I will talk a little bit more about this in the subsequent slides. So what is nasopharyngeal carcinoma? Essentially, is defined as a cancer that develops from the lining of the nasopharynx. It is also known, locally as nose cancer. And of course, in the nasopharynx, there are many different cell types, and different cell types can actually give rise to different cancers. And the most common cell type that we see in Singapore is actually a squamous cell carcinoma. So nasopharyngeal carcinomas actually affect men more than women. And unfortunately, based on the Singapore Cancer Registry Annual Report 2019 that was published earlier this year, it is the 8th most common cause of cancer deaths amongst males. And of course, it's also the top 10 most common cancers by incidence for males between 30 to 59 years old. and of course, there's a tendency to run in the family. Now, we also need to know a little bit about the risk factors. Of course, like what I mentioned previously, it occurs more commonly in males. It also is a higher incidence in people of Southern Chinese descent, and of course, a family history of nasopharyngeal cancers, in which there's 2 or more first-degree relatives with NPC, and first-degree relatives can be defined like such as your parents as well as your siblings. And of course, a previous Epstein-Barr virus infection, which most of the population in Singapore would have it already. And of course, a diet high in salt and preserved foods. So moving on to the signs and symptoms, I think basically nasopharyngeal carcinoma can be very insidious, like what was introduced to us is actually a hidden disease, because at the early stages, it can be completely asymptomatic. And, and of course, the signs and symptoms actually may develop as the cancer progresses. And I think to illustrate this is that on the bottom right clinical photograph of the nasopharynx, you can see that there's a mass growing in the nasopharyngeal area. And such a small tumor may actually present with no symptoms at all. So this patient that was seen in the clinic actually presented with very non-specific throat symptoms, and his scope performed for him incidentally picked up this mass at the back of the nose. And I think to better understand why some of the symptoms and signs occur, I think it's best to first understand, what are some of the surrounding structures in the back of the nose. So I think let's just focus on the photo or the diagram on the left side first. And this black arrow actually points to where the nasopharynx is. So you can see if there's a tumor that grows out from the nasopharynx, it's actually in very close relation to the first structure that I mentioned at the start of the talk, which is the eustachian tube. The function of the eustachian tube actually is to equalize pressure in the ear, and also secondly, to drain out whatever fluid that's produced in the ear. So you can imagine if there's a tumor that's blocking off the eustachian tube opening, it can cause problems to the ear. Now, secondly, in this diagram, there are photos showing a lot of nerves. These nerves may not be affected by the nasopharyngeal carcinoma, but I just wanted to illustrate the point that there are many nerves and vessels surrounding the nasopharynx, and these nerves and vessels can also be affected. Secondly, and lastly, of course, on this diagram, you can see that it's also very near bone. So the bone in the spine area can also be affected as well. Then we change our attention to the photo onto the diagram on the right. You can see that actually although this is not a cut where the nasopharynx is, but behind the nasal cavity, this photo in the center shows the nasal cavity. Behind it actually sits the nasopharynx, and the nasopharynx is actually very closely related to the eye as well as to the brain. So some of the nasal symptoms that you can get, or what I group off as the nasal symptoms, would be number 1, blood stain, phlegm, and saliva. So you can imagine if there's a tumor that sits in the nasopharynx, and because of its connection to the throat, blood can actually drip down the back of the throat, causing patients to present with a blood stain, phlegm, or saliva. And if somehow the blood or the tumor is big enough and it flows out through the nasal cavity, patients can also present with nose bleeding as well as bloody nasal discharge. And of course, you can imagine if the tumor is big enough, it can block off the back of the nose, causing blocked nose that can start off as a single-sided blocked nose and then progressively becoming, it can occlude both sides of the nostril. The next signs will be in the ear. Of course, like I mentioned just now, if the tumor blocks off the eustachian tube, it can actually cause fluid to accumulate in the ear. This can result in hearing loss. Sometimes with the hearing loss, our patients may also just present with blocked ear sensation if the eardrum or the eustachian tube, is not totally occluded, but just partially occluded. And also because of this blocking, patients can also hear a ringing sound in the ear that's persistently there. Well, other symptoms, neurological symptoms, like what I mentioned just now, is very close to nerves. So patient can present with facial numbness. Patients can also present with double vision when the eye is directly involved, 1 or 2, if the nerves that control the muscles of the muscles of the eye is affected. And of course, if it affects the brain, it can cause headaches. Patients can also present with a painless neck lump in the neck, like this gentleman in the photo on the right. Patient actually presented with a neck lump, and this spread of the cancer to the lymph nodes. And of course, patients can also present with symptoms of distant spread if it's a very advanced disease of spread to the lung, liver, and the bone. This can result in pain, such as if it's to the spine, it can cause back pain, or it can, to the lung, it can cause shortness of breath or cough. I think when should you seek help? I think basically if you have any persistent symptoms for more than 2 weeks, or any signs and symptoms that worry you, that is also persistently there. And of course, if you have a strong family history of nasopharyngeal carcinoma, and that is defined like what I mentioned previously, if you have 2 or more first-degree relatives. So just very brief about the diagnosis and management, because it'll be, like what I mentioned, covered by my colleagues later. So when you come and see us in the clinic, the head and neck surgeons or the ENT surgeons will do a couple of things. Number one, we will do a complete head and neck examination. So basically, we'll examine you, in the head and neck region completely. And of course, second, and this is completed with the examination of the nasopharynx using a scope. And then if we see anything that's abnormal at the back of the nose, we can then, do a simple biopsy in the clinic under local anesthesia. And of course, let's say if there's a neck mass, we can also perform a very small and quick needle biopsy under local anesthesia. The results will usually come back within 1 to 2 weeks, depending on the institution. And then after that, if it's confirmed to be cancer, we definitely move on to staging. And staging is done using scans. So the scans, we will do a scan of the head and neck region, especially in the nasopharynx, as well as the neck. And then after that, we also do staging scans looking at the rest of the body. So let me just show you a video of a simple scope that we do in the clinic. It will start off from the left nostril, and then it will quickly switch to the right nostril. So I wanted to show you what we are seeing in the clinic. So it starts off with the left nostril, and we are moving through the left nasal cavity, going into the nasopharynx. And so this patient has a normal nasopharynx. You can see the eustachian tube actually opening on the left side of the video, or on your right currently. And then we are flexed over to look at the opposite the eustachian tube opening. You can see actually the nasopharynx very close. And then we can also flex our scope down to look into the throat. So this patient's throat has undergone some form of surgery. You can see the vocal cords very well. And then we can come back out to have a look at the nasopharynx again. And then we will then examine the rest of the nasal cavity. And this procedure is then subsequently repeated on the opposite side, which is the right nostril. So we are moving through the nasal cavity, and looking at the nasal cavity again. And then we have another view of the nasopharynx at the back and the eustachian tube openings. Okay, so the management of the disease is based on, very briefly, based on a couple of factors. So number one is the size and the type of the location of the tumor. And of course, the stage of the disease and the patient's general health. And of course, the details of treatment will be covered by my 2 other colleagues later. So I think just wanted to do 2 quick case examples of patients that I've seen in the clinic. The first one is, of course, an atypical case that occurred in a female. Although it occurs mainly in the males in Singapore, but it can also occur in the female. So this is a 38-year-old Chinese female that had no family history of nasopharyngeal carcinoma. She actually presented with very subtle left neck swelling for about 2 months with a left block ear sensation. And she also had some blood-stained saliva. So we look into the ear, you can see actually this is the diagram of the left, a photo of the left ear, and you can see there's some yellowish fluid that's actually sitting in the middle part of the ear that's behind the eardrum. And this is suggestive of what we call fluid in the middle ear. And then we did the scope for the patient. You can see at the back of the nose, there's actually a very big tumor that's occupying the entire nasopharynx. And this is in contrast to the scope video that I showed you just now. So a biopsy was done for her, and it came back as positive for nasopharyngeal carcinoma. We sent her for treatment, and I've been seeing her in the clinic for the last 2 years, and she's well. So the next case, just wanted to illustrate a point that patients can actually present with symptoms other than the symptoms that are presented. So it's a 50-year-old Chinese male that I saw recently, no family history of nasopharyngeal carcinoma, had a presenting history of just some runny nose for 6 months associated with a cough with no other symptoms. And of course, when we did a scope for this patient, there was a mass actually at the back of the nose. and I actually did a biopsy for him, and he came back positive for cancer, and he has chosen to return back to his home country in China for further treatment. So with that, I've come to the end of my presentation. Thank you very much for your time.
Talk, very nice introduction to the signs and symptoms of the nose cancer, which we are talking about today. The next segment will be delivered by Associate Professor Chua, Melvin Chua, who will be talking to us about the treatment for nasopharyngeal carcinoma and what is it that the patients need to undergo once the nose cancer has been diagnosed as described by Dr. Tan. Dr. Chua, please go ahead.
Thank you, Simon. Can I just allow me to share screen? Okay. Continue. So thanks for everyone for joining this morning's webinar. And I think it sort of gives me a bit of time to sort of go through some of the treatments that we do for NPC, and which is essentially nasopharyngeal carcinoma for short. And I'll try to dispel some of the myths, and I'll sort of try to do that with a lot of photos. So, I'll take some time to explain what it entails with regards to chemotherapy, radiation, and how do we sort of coordinate the follow-up with these surgeons. These are my disclosures, nothing relevant to my talk. So I thought I'll start with a case. So this is a patient of mine. Fairly young chap who came in with, basically blocked nose. As you can see, this is the MRI scan showing that this is the right, this is the left, that can appreciate some asymmetry on the left-hand side. And then it's very close to the bone that's separating the nose and the brain. And this is another section here where you look at the patient face on, and you can appreciate that there's some thickening on the left side. Now, it's easier to appreciate this on the PET scan, which you show here, where essentially everything that's maybe potentially cancerous, ignoring the brain, is bright. So, this segment here you see in the nose would match that to the MRI. And so I'll go through how we stage nose cancers later, very briefly, but essentially, apart from stage, the point I want to highlight here is we look at, when we think about treatment, we think of the risk of the patient, and we adopt several parameters beyond stage to then decide what should be the appropriate treatment for the patient. And we looked at a viral marker, which I'll sort of go through briefly. So this is EBV DNA, which is a liquid biopsy. That's a clinically available test that can be done for patient, and naturally speaking, the higher the level, the more aggressive or high risk the cancer would be. And then also we look at other things, including the volume of the disease. So here is demarcated as GTVP, but it reflects the volume, and anything more than 45 or 50 cc usually would indicate that there's a big tumor. And so, but the point to the patient is, how do we treat this young gentleman, right, who is essentially just turned 40s and got a long life ahead of him? And just to take a step back and bring us, refresh some of the facts again to the public. I think one of the things that I find people always ask me is, why do I get nose cancer? Why is it so prevalent in Chinese? And the point is that this is a unique disease with a specific geographical distribution. So here you see that it affects some of the, very north parts of America. So it used to be known as the Eskimo disease. In fact, we do see people in the northern belt of Africa transitioning to the Middle East, getting nose cancer. I think this speaks to the human migration pattern. But speaking about Asia, while China is shown as a high-risk region, in fact, it's primarily the southern China belt down to Vietnam, Singapore, Malaysia, and Indonesia. That's where essentially the southern Chinese migration. Whereas you look at the northern part of China, NPC is actually a very low in incidence. Now, you hear this a lot, and the truth is this. I mean, Epstein-Barr virus is a virus that is, very endemic almost similar to COVID. All of us get it or exposed to it when we are young. But in essence, it's a combination of being infected with this virus when we're young, then plus the Southern Chinese genetics, then add them together, they're sort of predisposed, not all, but predisposed Southern Chinese, meat, the Teochews, the Hokkiens and all that, to be susceptible to nose cancer. And in fact, the link between this EBV and nose cancer was established way back almost 50 years ago. If you look at this, where the first discovery was made by, Sir John Ohl, and when they found that there was actually EBV genome detected in MPC cells in 1973. So what are some of the stages and how do we stage? So naturally, stage 1 will be very isolated. Stage 2, you start seeing early spread to the lymph nodes because the nose is a very rich organ with lymph node channels. I always describe lymph nodes as train tracks. My patients, where you just imagine there's a train tracks leading from the nose itself, but still they're not big. And then stage 3 is when it invades around the region. So the brain, the lymph nodes, it starts going to both sides. And then stage 4 is when it starts going more superiorly, that means above to infect the brain. And then, or in fact, it hits the nerves, or it starts spreading downwards. And I'll show you more pictures later. And of course, now the thing is that we've got to make the distinction between stage 4A and stage 4B, because essentially stage 4A patients are still curable, while stage 4B patients is when MPC has already spread to the lungs, the liver, and the bone. And these are the 3 common sites where MPC or nose cancers like to travel to. Now, what is this humbling and staggering fact? Now, if you look at the breakdown of stages across all new MPC cases that are diagnosed in Singapore every year, and this is data from the Singapore Cancer Registry. If you look across from 2008 to 2017, over a 10-year period, the point I want to make here is that if you look at the breakdown of stage 3-4 patients, in fact, I always tell my patients, 50% of patients, when they first present with stage 4 disease. Now, this has not changed, despite perhaps one could argue the growth, the affluence, the improving affluence of our general public, the increasing awareness of health and everything. But despite that, patients do present with advanced disease, and it's often through no fault of the patient. In fact, because nose cancers tend to be very insidious, with minimal symptoms. And sometimes patients may present very early on, and when we do a scan, we realize that the tumor has been more extensive than we originally imagined. Now, the other staggering point to make is that MPC is a health problem that affects young males. Now, I'm not trying to be gender biased here, but the reality is if you look at the statistics between a very niche age group of 35 to 65, and this is data reflection of the Chinese male population, you see that in the early years, in fact, nasopharynx in this age group belongs to one of the top 3 cancers. And even though the incidence has gradually dropped over the years, it still remains at a very high incidence rate among this group of population. Now, why is it so important to highlight this fact? If you then think in terms of this disease as being something very curable, then we're speaking about a group of patients where they are at the peak of their social economic activity. And then fast forward, if you imagine that MPC patients tend to live to, on average, Singaporean males living to 83 years old based on our median life expectancy, then essentially if you have a patient diagnosed at 40 years old, then you're looking at a 40-year runway where in terms of not just cure, but quality of life issues play a big part in terms of deciding the intensity of treatment and the subsequent quality of life. So I think this is often what we think about when we see a new patient in our clinic. So to set a stage, I think just to recap, what is the, how do we stage nose cancer? So this is the nose, and as nicely shown by Dr. Leonard Tan earlier, when you do a scope, this is what you essentially see, the full view of the nasopharynx. But often, if you look at just the proximity, how close the bone is to the nasopharynx, it doesn't take a lot for the tumor to just hit the bone. And when it does, naturally, this patient becomes a stage 3 nose cancer. Now, when we talk about neck disease, again, this is how we stage nodal metastasis or lymph nodes in the neck in NPC. When it just goes below just the Adam's apple, then this patient becomes a stage 4A NPC. So again, the point to make here is that it doesn't take a lot for a patient to essentially go from early stage disease to advanced stage disease. And this is how we stage, but the point just to make here is that the majority of patients, as I've shown in the earlier statistic table, present with stage 3-4 NPC. Now, what we do notice, and interestingly, is we see a nice dichotomy of how patients present to us in the clinic, which makes us think about the value of screening. Now, we see some patients where the disease, for some reason, is very, very limited. They may be picked up on screening, or they may have very mild symptoms like blocked nose or blocked ears. And then when they come and we scan them, we realize that lo and behold, the cancer is very limited just in the nose itself. Now, but interestingly, I do have a group of patients where they are, again, working individuals, with good jobs and are very conscious of their health. But when they present with headaches, loss of vision. And again, when we scan them, we realize that this patient already have stage 3-4 nose cancer. Now, sometimes we see patients whereby, although when we examine them, we see a very small tumor in the nose, but when we scan them, we realize that, in fact, the cancer started spreading down the lymph nodes, and in fact, it's sort of gone very extensively downwards. So again, it's kind of very unique and interesting why, despite this being a common disease, that we have patients with such distinct presentation. Some patients present only with very local symptoms, whereas some patients present with extensive neck disease. Now, of course, we have a subset of patients with very extensive disease, both with a lot of local symptoms as well as bulky neck nodes. So these are some examples. So this is a patient of mine again with very bulky nose cancer. So if you look from the front, from the scope, you will see that this is very small, but in fact, when you do a scan, you realize that the cancer sort of extends more, we call it posteriorly and to the right, where the patients manifest symptoms of chewing and a bit of headaches because it's invaded the muscles on the back. This is another example of a patient of mine where you can see that, again, if you just look at the face-on view of the MRI, then this patient actually have a very small tumor in the nose. But when we do an MRI, we realize that the tumor has in fact gone upwards, but not downwards, where it started hitting parts of the brain and so forth. And this patient then manifested with headaches, nerve problems, facial numbness, and so forth. But the point is that ultimately, with the treatments that we have these days, I'll show you later that the cure rates of these patients are actually very high. So what is the simplified version of how we think about, matching stage of disease to treatment, which is the main topic of my talk? I think suffice to say, for stage 1 nose cancer, we've seen the recent news of, MP Biam King, where he had stage 1 NPC and he was successfully treated with radiotherapy alone. Now, when the cancer gets a bit more extensive, sometimes in stage 2 patients, about 40 to 50% may still be adequately treated with radiotherapy alone, but there are some patients whereby the cancer is a bit more bulky, where it's a much larger tumor in the nose, or it's gone to the lymph nodes, and the lymph node, even though it's just on one side or very limited part of the neck, it's very bulky, meaning it's more than 2-3 centimeters. We might combine chemotherapy with radiation. Now, it's really in the advanced stage 3-4 patients where treatment can be a bit more complicated. It often, to simplify to the audience, it will require a combination of radiation and chemotherapy. And just not to confuse you all, the chemotherapy and the radiation can be sequenced in many ways. Simply put, often in these patients, it's inevitable to receive radiotherapy with chemotherapy given together, meaning that when the patient undergoes radiotherapy, it's daily sessions over 6 weeks. So it comes out to about 30 or 35 sessions. And then on some of the days of the radiation, they'll receive chemotherapy. But additionally, for some patients where we think that the risk meaning the risk of spread to the lungs, liver, and bones is very high, then we might add more chemotherapy either before the radiation or after the radiation. And so this summarizes the treatment schema for stage 3-4A NPC. Now, of course, if the cancer, we find that the cancer has already spread to the other sites, then systemic therapy, meaning that chemotherapy first, and or with or without immunotherapy would be the first line treatment, because that would be the first backbone, the key backbone, where you're really trying to eradicate and shrink the cancer all around the body, including the nose, the neck, and elsewhere in the liver or wherever you're spread to. So I won't go into details here, but the point I want to show with this slide, so this is the updated algorithm or treatment pathway of how we would treat nose cancer. But it emphasizes, or it sort of illustrates to you all that there's a wide degree of heterogeneity in terms of the different pathways you can take. And the impression I want to make to the audience is that we don't just speak to stage alone. In fact, we are compelled by a lot of precise markers that we have, be it the PET scan, the liquid biopsy, that we can actually decide or break down patients by stage into even more specific treatment pathways to then decide how much to intensify and how much to de-intensify the treatment so they can spare their side effects. And what about the cure rates, which would be the interest of everyone here? Now, of course, this is based on data of 1,000 patients that we looked at. They were treated in NCCS, and in terms of 5-year cure rates for stage 1-2 NPC, I'm pleased to say that we're looking at above 95% survival rate. Now, one important point to make here is that if you look at stage 3 nose cancers, we're still, despite this dismal sort of pictures I've shown the patients, in fact, more than 85% of patients remain cured. And if you look at stage 4 patients, still the odds of being cured is in the range of 60-70%. Now, the point I want to make here is that these cure rates are only achievable because we are able to match the right treatment to the right stage. So meaning that if you have used radiotherapy just to treat stage 3-4 nose cancer, then you're looking at a much lower chance of cure. So I think it's important to make that impression across to the patient that if you do come with aggressive disease, that it requires a combination of treatment, and just one modality alone is unlikely to achieve such optimistic results. Now, I'm also happy to say that despite, even in patients with terminal nose cancer where it's spread to the lungs, liver, and bones, we're still looking at an average lifespan of 2 to 3 years because of the slew and the broad spectrum of drugs, and in combination with radiation and surgery that we can do for patients these days, that could actually achieve a lasting disease control. So in the next segment of my talk, just for a few minutes, I wanted to sort of bring you through what is the treatment pathway and the process. I can't go into too much details here because some of it may be too complicated, but I'm happy to do that during the Q&A. But it helps to dispel some of the concerns of patients, and I think also to showcase that how advanced the treatments have come along the way. Now, as part of radiotherapy, there's a few processes patients have to go through. First, a mask has to be made, because why? We do the mask before a scan. Now, sometimes I get patients asking me, "Oh, Dr. Chua, I just had a scan done, before I came to see you. Why do I need to do a scan again?" Simply put, because radiation is very precise. We need your head to be in a similar position every day for treatment, and therefore this mask has to be made. And then once the mask is made, we'll then do a scan for you, whereby we'll use that scan with your neck and in that specific position, and then myself and my colleagues will actually outline and delineate the target where the tumor is and the area that we're going to deposit the radiation dose. And so this is essentially what we do. Now, when we do the planning, we include information from all the scans, not just the CT scan, but we repeat the MRI and the PET scan with the mask in place so that we can register all 3 images. Now, the point is that you want to leverage on the available and advanced imaging modalities that you have so that you get the best of all information. So when we do that, it's essentially an illustration of what I would outline. I will essentially draw the tumor based on what I see on the CT scan, the MRI, and the PET. And so then you get a very accurate delineation of the tumor. Now, beyond that, if you look at this, in this example here, if you look at the green line, this is where the nose cancer is for this patient. But we can't just treat that area itself. So when we talk about precision treatment, I think patients always get, a bit concerned and they're worried about side effects. And they will ask me, say, doc, why don't you just take it out? Or why don't you just treat that area? But because nose cancer can spread, you see, if you look at the brain itself or the nose region, you see all these little holes here. And these are holes, essentially, they are very soft bone where the nose cancer can infiltrate. And so when we treat, we have to treat a region around the nose itself. Now, but it's important to highlight that in this, what we call microscopic region, where this region are not perceived to be involved, we don't have to use a high radiation dose. So we use a much lower radiation dose to spare side effects, but this is a dose that is sufficient to neutralize any cancer cells in this region. So the thing is that this target delineation process, this radiotherapy treatment process, is a very detailed, almost akin to surgery, but it's done in front of a computer. We plan it, we draw the target, and then after that, together with our physicists, we outline where we want the radiation doses to go. So I'm glad to say that we've come a long way from the two-dimensional era. We used to give radiation, not in my time, but I was fortunate to see it just as I was doing my training, 15 years ago, where we were doing sort of x-rays and then using a crayon, drawing where the tumor is, and then drawing lines where we would actually block out the radiation field. So we will block out ulcers in the mouth, block out radiation to the brain, and then so forth. But the point is that when we did that, and patients always talk about, my uncle was treated 30, 40 years ago, and he had such severe side effects. And simply put, because we had limited ability to shape our radiation dose. Now, if I were to just bring you through this very quickly, this is a patient that was treated using the old technique, where you see there are two fields, one on the left, one on the right. And if you look at these other radiation lines, what you essentially see is everything gets treated with a single radiation dose. So there's no way, even though this is your target, to shape the radiation dose around this curvy target, and everything from the cheek, the bones, gets a uniform dose of radiation. Now, we have come a long way, this from 3D to being able to draw the target, now to being able to shape the radiation dose, and to quickly show you these days, how do we treat patients? Now, when we started IMRT about 6 or 8 years ago, which is intensity modulated radiotherapy, we have now evolved a technique now to what we call ARC therapy, where we have in essence been able to treat the patients from 30 minutes using the old IMRT technique to now 7 minutes, where patients lie down, the mask is slapped on, and using just two cycles of radiation beams, means going one circle and another circle after that, we're able to complete the treatment of the patient. And now, how are we able to achieve very steep dose gradient? So what I mean growth gradient, meaning dropping the radiation dose from the maximum to the lowest radiation dose. And because if you look at the beams here, every single degree, we are essentially modulating how much radiation beams go through. And just to show some example, if you look at the different percentages of dose, so the green line here demarcates the full dose, and then the orange line is 50% of the radiation dose. We're able to really push the radiation dose away from the oral cavity, which is the mouth, away from the spinal cord. And if you look at some of the other areas you can spare, for example, like the brain, we're really able to push the radiation dose downwards so that a big part of the brain is spared from high dose radiation, where it really causes a lot of damage. If you look at the salivary glands, where the saliva is being produced from the side, we're able to really push. And in fact, here you can look at the 20% radiation dose is actually away from the salivary gland. So part of the salivary gland, in fact, gets spared from any radiation. If you look at the throat looking downwards, again, you see a sparing of this midline structure. So we can afford to do all that now, so that this actually helps to minimize the severity of the symptoms. Now, patients do get side effects, don't get me wrong, but it's just the severity is a lot more lessened, attenuated. So this is an example of a patient of mine, 50 years old, very active, stage 1 nose cancer. He underwent 30 sessions of radiotherapy. This is the tumor on the left side, seen on MRI. You see this on the PET scan. And this is the radiation regime that we designed for him. We gave the full radiation dose to the main tumor. We gave a lower radiation dose to the surrounding organs, and then to the rest of the nose, part of the neck, and in fact, the opposite side of the neck gets a lower radiation dose, and then a lesser area, and then the same side gets a much more extensive or comprehensive radiation, but to a 80% a 30% reduction of the full radiation dose. You can see how tight the radiation delivery is, where we try to really treat the target that we want to irradiate. We don't treat the whole big area extensively, and then really make an effort to spare toxicities to the brain, the salivary glands, and the other parts of the organ. Now, what are some of the side effects? Briefly, I think they go in chronological order and over time. The first week, patients are very well. The second week, almost 90% of patients will tell me this thing, that, oh, Dr. Chua, I've lost my taste. I can't, everything seems very bland. My mouth is dry. And this is unfortunately the case, but it does recover about, 1 to 3 months after radiation is completed. Majority of patients do recover 90% of their taste buds. Now, over the course of treatment, the mouth does become more dry, but by about the halfway through treatment, they'll say that there's pain when swallowing, but the pain is not really pain, but it's manifested by the difficulty in actually swallowing a regular diet. So when they eat rice, chicken, they find that it's really hard to put the food through because the muscles are weakened. So that's why during treatment, we do link our patients up with speech therapists who tend to teach the patient exercises to try to sort of, retain and prevent further deterioration of this side effects. And then about week 5 or 7, often patients are still well. They don't really need feeding assessment. We encourage them to have milk feeds, porridge kind of diet, but they do lose a bit of their hair, not the top, but just around the sideburns, and then they get a bit of weight loss. But we do expect a recovery within a month after radiation. Now with chemotherapy, again, just to emphasize, it's not the classical chemotherapy where you see patients vomiting away and losing their hair. The chemotherapy that's being used for nose cancer is a bit more specific. Often the common symptoms are more related to constipation, a bit of nausea, and loss of appetite. So I think when you put them together, it can compound these side effects. And often that's why during the weekly reviews of the treatment, we do watch the patients closely to make sure that they are able to sort of get through. This is just some examples. This is, again, very severe burns, but this is a 67-year-old patient who underwent chemotherapy and then chemo radiation. So it's a very long course of treatment. And I'm glad to say that she has recovered subsequently. And this is another patient undergoing chemo and radiation. This is her skin at the end of treatment. And often this is at the angle of the neck and the shoulder is where they get a bit more sort of burns. But you can see that about within 2 weeks, much of the skin has healed, and I just encourage them to put moisturizers after that. And this is her when she saw me a month later. But importantly, you see that in the patient I showed earlier, within a month, 2 months post-radiation, you can see that there's complete resolution of the tumor. I think this is what often patients look forward to, that with a very specific treatment, with minimal downtime, still being able to travel daily for treatment, that they actually do a full recovery. Now, finally, just to highlight that one of the points, a brief point to make, that these days, we're glad to say that we actually have a blood test that's able to allow us to do screening, track patients when they first see us, and then also assess whether the treatment is a success, and then even for follow-up, because we can't do scans of patients all the time. By a simple blood test, we can determine whether this patient is still in remission or there's early indication of the cancer coming back. And so finally, with the last part of my talk, I would like to just sort of do some advertisement here and I'm very glad to say that the Ministry of Health, together with the National Medical Research Council, has actually invested in a $10 million national program that's specific for nose cancer. And it will cover basic discovery, and it's a collaboration across several institutions on the island, and it will cover novel discoveries as to the genetics of nose cancers. Why do people in Singapore remain to get nose cancers? And in fact, Malay patients do get nose cancers as well. And it also covers screening, and then also looking at personalized treatment based on your patient's risk profile, and so that we can actually accelerate drug discoveries for patients who actually require new drugs to extend their survival. So with that, thank you for your time, and happy to take any questions later.
Thank you very much.
So we're gonna stop here with presentation. You have the reminder of the video there to watch. There's a link, and we're gonna have a short break. Thank you. Okay, so we're going to continue now. We'll look at animated video for esophageal cancer. And later, we're going to look up at another presentation of esophageal cancer as well. So let's start with the first brief video on medical video animation on esophageal cancer.
Esophageal cancer is a disease that begins in your esophagus. Your esophagus is a muscular tube that food passes through from your mouth to your stomach. The flat, thin cells lining your esophagus are called squamous cells. Below the surface, cells divide and flatten to make new squamous cells as the old ones wear out. If you have a condition called gastroesophageal reflux, or GERD, you frequently have a backflow or reflux of acid from your stomach into your esophagus. Over time, GERD may cause the squamous cells lining your lower esophagus to be replaced with gland cells that make mucus called goblet cells. This change in the lining of your esophagus is a condition called Barrett's esophagus. One type of esophageal cancer, called adenocarcinoma, may occur in the changed lining of Barrett's esophagus. Another type of esophageal cancer, called squamous cell carcinoma, occurs in the squamous cells in your esophagus. Like all cancers, both of these types begin when damaged or abnormal genetic material inside your cells causes them to grow out of control. A tumor forms as the abnormal cells begin to multiply. Over time, a lump may form in the wall of your esophagus as the tumor grows. You may have no symptoms in the early stages of esophageal cancer. Later, you may have trouble swallowing when the tumor becomes large enough to block part of your esophagus. Having trouble with swallowing may cause you to have difficulty eating. As a result, you may lose weight in a short period of time. Depending on the location of the growing tumor, you may also have pain in your chest or neck. If you have esophageal cancer, your doctor may recommend one or more of the following: surgery, chemotherapy, and radiation therapy. Surgery is the most common treatment for esophageal cancer, especially in the early stages when the tumor is small. If you have a surgical procedure, your doctor will remove the section of your esophagus that contains the tumor, as well as some normal tissue above and below it. The surgery may include removing part of your stomach. The remaining healthy esophagus and stomach will be attached to each other. Your surgeon may also remove nearby lymph nodes to see if cancer cells have spread to them. Your doctor may recommend chemotherapy as a main treatment for more advanced tumors or to shrink your tumor before surgery. Chemotherapy uses drugs to stop cancer from spreading by either stopping or slowing down the growth of cancer cells. Your doctor may recommend radiation therapy, such as external beam radiation therapy, in addition to chemotherapy. Radiation therapy damages and kills the esophageal cancer cells. Some common ways to reduce your risk of esophageal cancer include seeking treatment if you have gastroesophageal reflux or GERD, quitting smoking, and avoiding alcohol.
Okay, so that was a short medical information video on esophageal cancer. So we'll look at our textbook on esophageal cancer. So here the book mentions that it's the 8th most common cancer in the world, and in certain parts of the world is more prevalent, in others is less. As we saw from the video, it's connected with what we call rebellious stomach chi moving upward, or acid reflux, or sometimes called gastroesophageal reflux disorder, or GERD. Depending on when it's discovered, surgery may be the first one to use, followed by radiation, often external beam radiation, and chemotherapy or combination. So generally, presentations are difficult to swallow, sensation of something being stuck in esophagus, swelling of the neck if it's more projected upward. And etiologically, pathologically, we see 3 themes: depression and binding of liver qi, causing later on generation dampness and phlegm. Phlegm stasis and qi stagnation, so allowing growth of tumors, depletion of qi in blood due to debility in old age. So we see this more in senior population of patients. So we're going to look first at internal treatment, so depression and binding of the liver qi. So have discomfort after intake of the food, hiccups, oppression in chest, bitter taste in the mouth, distension and pain in hypochondriac region, headache, dizziness, irritability, and insomnia. Tongue is often pale red. Here they're mentioning thin yellow coating, sometimes maybe also thin white coating as well. Pulse is wiry, tready, sometimes feeble. Treatment principles: we have to soothe the liver, regulate liver qi, dissipate the lung. So we have here 2 formulas. We have free wonder, Bupleurum and Danwei Xiaoyao San, combined with inula and hematite decoction, Shuangfu Daijie-tong. And of course, there are some modifications to these 2 formulas. So again, the first formula is there to reset the liver, and the second one targets the lumps. Second pattern we're looking at is phlegm stasis and qi stagnation. So again, inhibited food intake, low appetite, stifling, oppression of the chest, and distension after eating, problems with full diaphragmatic breathing, discomfort in chest and the back, mostly mid-back, cough that's productive with profuse phlegm, nausea, possible vomiting, with the mucosoid vomiting. Tongue is often swollen with 2 teeth marks and white or thick greasy coating. Pulse is wiry and slippery. So we have to transform or thin the phlegm here, dissipate the stasis, and then redirect the qi downward, as well as dissipating lumps. So again, we have combination of 2 formulas, where the second one was already used in the previous one. So we have Frutilari bulb and Trichosanthus fruit powder combined with inula and hematite decoctions with modifications. So it's Bei Mu Gualo Sun He, so combined. Shuangfu Daijie Tang Jie Jian. So the first formula again here is thinning the phlegm and dispelling the stasis. And this other one is dispelling the lumps. Depletion of qi and blood due to debility in old age often happens in patients generally after 70. We have dysphagia, emaciation, and lack of strength, sallow yellow, dull white complexion, often spontaneous sweating, low appetite, vomiting of the mucus, and because of acid reflux, hoarse voice. because it changes the oral mucosa in and around the oral cavity and down in the esophagus, around pharynx and larynx. Tongue is pale with thin white coating, pulse is deep, thready, and sometimes weak, feeble, or forceless. So treatment principle is to supplement qi, nourish the blood, and transform phlegm and dissipate the lungs. So again, the second formula is the Nuland hematite decoction that targets the phlegm and dissipate the lungs. But the first one is actually blood and qi tonic. So that's the Shi Huang Double Tongue. Perfect major supplementation decoction, or often called also all grade 10 herbs tonifying decoction as well in English. So that will be due to debility in a senior age, right? So acupuncture can be used as well. It's often combination of the points on locally, so in and around like a trunk, so from throat down, and sometimes distal points. So so we have CV basically 12, 13, CV 22. Sometimes we also have CV 17, large distance 17, and PC 6. Those are the main points. Auxiliary points may contain additional points triggering some secondary presentation. So if the cancer is in upper part of esophageal parts, we add CV21, bladder 15, because that's the sort of level of trunk where the cancer may be. For cancer in the lower part of esophagus, we add CV14, bladder 18. For vomiting and profuse phlegm, adds Fenelon. Stomach 40. For oppression, pain in chest, we add Kegel, large intestine 4, PC6, NEG1, CV20, and stomach 18. For overall qi deficiency and lack of strength, we add stomach 36 and CV6. So usually REN 22, REN 17 are key points to manipulate. Naturally, here in the West, as I mentioned before, we end up treating more so in the treatment stage of biomedicine. So surgery, post-surgery, post-radiation, post-chemo, or during radiation and chemo. So before surgery, a TCM can support overall Zheng Qi, making post-surgical recovery faster. In post-operative period, we have depletion and damage to qi and blood, because surgery itself may result in losing of blood and qi, and spleen and stomach disharmony. And there are some herbal hospital formulas that we can prescribe. So often these are the qi and blood tonic formulas, or qi and yin deficiency formulas. Acupuncture can be used when there is side effects such as difficulty in swallowing, so dysphagia, either from obstruction from phlegm or weakness of the qi. So points like stomach 36 combined with bladder 21 to boost the stomach and spleen can be used. PC6, lower connecting point for yin wei mai can be used. Combining again CV17, CV22, needling downward can treat systemically and locally, right? Ear acupuncture can be used in between the treatments, so esophagus, stomach, and shenmen. We can also add 0.0 as well. So in radiotherapy or radiation, internal treatment may be focusing on side effects from toxicity caused by radiation, so clearing heat and toxicity activating lymphatics, and we see here a hospital-based formula, oncological formula for that. Cooling and supplementing qi and blood, again, anti-inflammatory and tonifying formula targeting qi and blood. Generating body fluids and moistening dryness, so often formula based on Liu Wei Diguang 1 or Yiguan Jian, linking the decoction of Romania 6 to better reposition fluids in the body. We can also focus on treating particular syndromes like fortifying spleen and harmonizing stomach for poor appetite as a main symptom, because If patients cannot eat, that's considered a bad sign. Now, in modern medicine, that can be circumvented for a time being with intravenous therapy. Of course, we don't have access to this as a TCM practitioner in the West. Our colleagues in China have, and we can always refer patients here in a hospital to have this. But eventually, you want to wean them off and get them to eat, because without them nourishing the so-called milojals, spleen, stomach, pancreas, there'll be no recovery. So then, combination of couple formats like xiangsha, liuzhenzetang, jiejian, so Clandia moment enhanced 6-gentleman concoction with modification, boost the spleen, stomach, and spleen. Xiaoyao, San Jiejian, Free Wonder, or Bupleramin Dan Gui can also help harmonize the liver and stomach and spleen. For nausea and vomiting as a main symptom, we often prescribe Erchentang, especially if there's a phlegm involved. Alternative formula would be Jupiju Tang Jiejian, tangerine peel and bamboo shavings with modifications to root the stomach qi downward and prevent nausea and vomiting. In chemotherapy, again, internal treatment boosts the qi in blood, fortifies spleen and stomach, enriches relation between liver and kidney, and relieves toxicity, transforms the phlegm, so thins the phlegm and dampness, then we get rid of dampness, but also activates the lymphatic system. So here we have a formula, it's a part qi and blood tonic, part basically detoxing formula. Overall combined therapy means that we use combination of herbs, acupuncture, nutrition, ear acupuncture, manual therapy if patient can tolerate, like visceral manipulation, laser acupuncture, qigong, of course, to supplement qi and blood, activate and maintain good lymphatic drainage, maintain good intra physiological support of organs, right? And reduce any or stop from replication any tumor or cancer. So early diagnosis of esophageal cancer is often a bit difficult because lots of people don't have major signs. So they're basically, the best way to do it is endoscopic camera scoping, right? And so if someone is suspecting things, they should, especially if there's in family or they come from culture where there's a higher incidence of esophageal cancer, they should consider having scope done once in a while. It's invasive procedure. Obviously, it's covered by OHIP. Ultrasound generally does not show much. MRI may, but sometimes it's easier to get scope than MRI because of the cost and wait list. TCM integrated early in the care can significantly improve recovery and prevent reoccurrence by increasing microcirculation of qi in blood, boosting zheng qi, and again, work on any of the side effects. Nutrition is also very important, and during the should be more in a liquid form, so it's easier to swallow. So mostly soups. Raw food and food hard to swallow probably would not work really well. For example, adding some of the apitherapy products like royal jelly in honey, propolis in honey, which is a known antibiotic, can also help tremendously nutritionally, but also to boost zheng qi immunity. Qigong also can be very good for self-care and maintain the basically overall immunity. Often patients may have difficulty sometimes sleeping because of acid reflux, snoring, so treatment for insomnia should be also included in it. So this would be a review of the common therapies that we may use. Again, depending on our role, most of the time here in the West, we're basically delegated to supporting roles. So after a patient is diagnosed, often we're in a role of supporting ongoing post-surgical radiation or chemotherapy treatments and working on the side effects of these treatments, as well as the boosting Qi and blood immunity and lymphatic system. Okay, so now we're going to shift toward our presentation, and we're going to look at Barrett esophagus and early esophageal cancer diagnostic webinar. So we're going to see how technology is used to early diagnosis, giving patients a better chance at later on at treatment of these. And this is presented by American Foregut Society. So let's have a look at it.
Hello and welcome everybody. I'm Subhash Chandra, and welcome to our American Foregut Society's monthly webinar. Today we'll be talking about Barrett's esophagus, kind of diagnostic aspect and surveillance options. Our first speaker is Dr. Prakash Gata. Dr. Gata has done medical school from Mumbai and his surgical residency from University of Illinois. After that, he has done minimal invasive foregut surgery fellowship at Portland, Oregon, and now works in Tacoma, Washington at Multicare Medical Associates. And he is the foregut guy in Puget Sound. He does links and tip surgeries for refractory GERDs, and have been selected as America's top surgeons by Consumers Research Council of America. He'll be talking today about biopsy protocol and use of warts in evaluating Barrett's for dysplasia. Dr. Gata.
All right, thank you, Dr. Chandra, for the introduction that I don't deserve. I appreciate the opportunity to speak here. I think for me, looking at Barrett's disease, esophageal cancer, and reflux as a continuum or a spectrum, and looking at it or researching from a diagnostic side, I've learned, I feel a lot, some of the things that we don't always see as surgeons. So one of the things that I wanted to set as expectations is if you were a foregut surgeon or that's kind of your clinical interest, I would look at esophageal disease as a pyramid. So the very tippy top of the pyramid is what we want to prevent, which is esophageal adenocarcinoma. And one of the things that over the last few years has been quite clear is that we have failed in finding a way to reduce the incidence of this particular cancer, with almost an 800% increase over the last 30 years. And this is multifactorial, but I believe part of the failure is our inability to come up with standard screening or diagnostic tools. Clearly that there is some correlation between the payer side as well as the ability to understand the disease as a whole. So it's one of the fastest growing cancers, certainly one of the fastest growing GI malignancies, and it's one of those potentially preventable cancers that we, as opposed to cervical and colon cancer, which the incidence has stayed flat, esophageal cancer, not so much of the case. In terms of treatment as well, it's a difficult cancer to treat, even if you were to diagnose it early. And as you can see, the 5-year survival rate has not been a significant increase over the last 20 or 30 years. So a big issue is what we're trying to do is find better mechanisms, essentially fix the problem that we believe is a problem, part of which is diagnosis. So in terms of if you're a diagnostician, if you do a lot of upper GI work and you're a gastroenterologist, the average gastroenterologist sees 20% of who they see are reflux patients on a daily basis. And as we all would know, there's a lot of specialists who also treat this disease, ENT, dentists, gastroenterologists, and pulmonologists. And along that care continuum, that spectrum, is a change in the mucosal pattern of the lower esophagus, essentially something that arises after years and years of damage from this acid and non-acid reflux, an irreversible change. We know, and then we call this Barrett's disease, Barrett's metaplasia, as well as dysplasia. And we also know there's a higher correlation or incidence of esophageal cancer with patients with this. Barrett's, the presence of Barrett's, the current way to diagnose it, at least endoscopically, is using NBI light, as well as experienced gastroenterologist as a protocol to be able to find and create a biopsy-proven area of dysplasia, which has a far higher correlation with esophageal cancer, is essentially our challenge. So this is what Barrett's disease would look like. So in terms of progression of the disease process, the change is essentially a change from squamous epithelium, which is then suffered by GERD and affected by GERD, a transition to Barrett's esophagus. And within the Barrett's metaplasia, the crypts that are formed, because now these are columnar cells, the crypts that are formed are usually likely the location for the dysplasia. And then there's two grades of dysplasia, low grade and high grade. High grade dysplasia currently can be treated as esophageal cancer. Between 4 to 18% of patients will actually have occult adenocarcinoma at the end of esophageal resection. And part of the diagnosis is to do an endoscopic ultrasound on patients that have higher suspicion for this disease process. So 20% of the US population will develop GERD. 8% of that 20% will develop Barrett's esophagitis, and the pathway of progression of that cancer will continue. Patients with Barrett's esophagitis have a 50 times more incidence of esophageal adenocarcinoma. And this is why surveillance and screening of Barrett's esophagitis is essential. This is one of the reasons we believe is the better screening is a better, more effective way of controlling this. So of the US population of 330 million, 66 million will develop GERD. So a huge denominator in the disease set that's out there. This is a busy slide, but I don't know if you can actually see the current surveillance, the current acceptable or accepted surveillance mechanism is essentially to follow the Seattle protocol. So you have to obtain tissue to diagnose the lower esophagus and to establish the diagnosis of Barrett's esophagitis. And once those histological findings are found, presence of Barrett's metaplasia, whether the biopsies are indefinite for dysplasia, typically what we do is recommend a rebiopsy at 3 to 6 months after initial treatment. But if there is an established diagnosis of Barrett's metaplasia and there's no evidence of dysplasia, typically we would survey these patients. Patients that are indefinite for dysplasia, sort of in between dysplasia and metaplasia, we would confirm the findings with a second pathologist, someone that would be considered an expert pathologist for esophageal disease, as well as follow-up endoscopy down the road. And if there is evidence of high-grade dysplasia or esophageal adenocarcinoma, of course, the patient will follow the pathway of the local, sort of the cancer protocol, where you have an esophageal surgeon see said patient. So what is the Seattle protocol? The Seattle protocol basically is the mechanism to obtain tissue biopsies using random 4-quadrant biopsies separated by 2 centimeters in the distal esophagus. And in patients with an established diagnosis of patients with suspected dysplasia or an established diagnosis of prior Barrett's metaplasia, it is recommended that there's a biopsy be performed every 1 centimeter. Now, what are some of the flaws of the Seattle protocol is that in terms of the amount of tissue sampling that is obtained, there's a huge resource. This is a resource-intensive mechanism where it's time consuming to obtain those samples, have every of those samples evaluate pathology. Most importantly, are you getting enough tissue, especially in the area where dysplasia may start, essentially deep down in the crypts. And if you look at the sort of biopsies that you obtain, there are still areas that are deeper from the superficial zone where tissue is not obtained. And more importantly, there's a lot of sort of user variance in terms of what Seattle protocol actually is, depending on training, local cultural practices, as well as the differentiation between pathologists who typically will review a higher volume of lower esophageal biopsies. So there's a lot of variation from the perspective of screening. And the goal essentially is to prevent or early diagnosis of esophageal cancer there's been data that shows that the Seattle protocol does not necessarily equate to a higher 5-year survival rate. So this is essentially the goal of that diagnostic process. So to summarize, the sampling error it's associated with a higher rate of sampling error in terms of intestinal metaplasia and dysplasia. Secondly, significant amount, this has been studied, a significant amount of inter-observer variability in terms of what the slides are actually representing. So 33% of esophageal, in this particular study, 33% of esophageal adenocarcinomas were diagnosed in this subset, in this particular study, on a patient that had a negative Seattle protocol index biopsy a year prior to the procedure. There was no significant mortality reduction at 5 years in patients where Seattle protocol was borrowed. So enter the Watts instrumentation. I present this as a way to essentially differentiate between the typical superficial biopsies as well as what a Watts instrument biopsy would look like. In terms of where the dysplasia is, these are the red cells that are deeper down in the crypts, the tissue diagnosis that we actually want. So those crypts are much better accessed using the Watts instrument. The area of tissue sampling is larger, and how Watts is different is the tissue obtained is run through a vision platform using artificial machine learning intelligence software that would allow for every biopsy is still reviewed by a pathologist, and I had a chance to connect with a company to figure out how a pathologist can obtain a specimen from a patient in Washington State where I'm at. How the pathologists work with this particular company is once the biopsies are obtained and these biopsies are run through their machine learning algorithm, what would happen subsequent to that is the biopsies that are concerning are red flagged to an expert panel of esophageal pathologists. And these pathologists have national licenses in all states, or how, as is governed currently, where the specimen is going, which is typically New York State, the pathologist has licensure in that particular state, so it's usually covered. But for pathology, it's not something I've had to think about before. If you send it out to another state, typically where the specimen is received in that particular state, the pathologist on that state can see that. But they have an expert panel who review every slide. And the difference between the technology is significant because a combination of the Seattle protocol with the Watts biopsies appears to correlate to a much higher rate of diagnosis of Barrett's esophagitis. Again, this is a good way to sort of summarize what happens. It's an interesting combination of an endoscopist performing the biopsy with this instrumentation, a machine learning algorithm that actually sorts through the histologic slides to look at which of these specimens actually are of concern, and then another one with a human being trained and specializing in this particular disease set that can review these particular slides. So this is a 3D rendering of what the specimens would look like using this particular instrumentation. Let me see if I can get this to play.
During an upper endoscopy, highly focal dysplastic cells are often hidden among mucosal areas of the esophagus, usually without any visible clues to show the clinician where they may be located. Watts 3D uses a specially designed biopsy instrument that covers a greater circumferential area of the esophagus, providing a wide area, full-thickness mucosal tissue sample down to the muscularis mucosa, gathering cells, cell clusters, and intact tissue fragments in a unique disaggregated specimen that is up to 150 microns thick. To overcome the challenges of a tissue sample that's 50 times thicker than a traditional histology specimen, Watts 3D uses a proprietary 3D imaging system with extended depth of field to capture all the layers of a thick smear into 20 to 40 independent sections, all in precise focus. CDX's patented technology merges the digitized slides into a single synthesized 3D image. This unique dimensional view of the specimen presents a much clearer image of cell nuclei and mucosal crypt structure, enhancing the pathologist's ability to examine cells in relationship to each other, ultimately leading to a more accurate diagnosis of Barrett's esophagus and dysplasia. Once the whole slide is scanned, artificial intelligence is employed to reliably identify dysplastic aggregates hidden among normal esophageal tissue. A neural network trained by expert pathologists uses an advanced algorithm to consistently analyze every pixel of the digitized specimen. First, the algorithm looks at a variety of lower-level features such as texture, color, shape, nuclear size, and nuclear cytoplasmic ratio. Then, it evaluates a combination of individual lower-level features, groups, and clusters, and compares these findings to a previously learned training data set. Finally, the computerized cell images are highlighted and ranked according to their degree of atypia. Areas identified by the AI system with the highest probability to be precancerous are then displayed via computer monitor to the pathologist, allowing them to quickly and accurately identify dysplastic cells that may otherwise have been hard to distinguish or even missed completely.
Essentially, it's very interesting software and sort of employment of latest technology along with human knowledge. And the result appears to be that, number one, there appears to be a lot more inter-observer agreement amongst pathologists with the newer mechanism of tissue sampling. And it also appears to translate into a much higher detection of the disease set that we're trying to not miss. So, and up to 167% increase. The yield is higher. There's a lot less disagreement among pathologists about the diagnosis, and hopefully this would translate into a lower rate of these cancers, 33% as we saw on that particular slide, a lower rate of missing these and earlier detection of the disease. So I appreciate the ability to present this very interesting subject for our webinar.
Thank you, Dr. Petta. We'll come to the questions at the end. Our next speaker is Dr. Houghton. Dr. Houghton is from Los Angeles, California. She finished her medical school at Wayne State, followed by residency at University of California, Irvine. She completed her minimal invasive surgery and advanced endoscopy fellowship at University of California, San Diego. Currently, she practices under Keck Medicine at USC. And she is well known for her expertise in robotic foregut surgery and pioneered their POEM program. She'll be discussing about cytosponge, biomarkers, and optical imaging in Barrett's surveillance.
Hi, how are you guys? Thanks for having me. And you know, Prakash's portion of the talk really sets us up for then what else can we do? And as we know, from what he said, Barrett's diagnosis in diagnostics traditionally has been the use of endoscopy with the combination of pathology. So you want to see the salmon colored tongues of mucosa endoscopically, and then have that pathology confirmed with the goblet cells in the esophagus. And as we communicate this with each other, and as we're diagnosing patients with Barrett's, we tend to use the PROG classification to document the circumferential margin and then the maximal extent. So as far as standardization of Barrett's, we'll often see that, you know, we can gauge from endoscopy to endoscopy whether this is progressing, regressing. And I think it's important for all of us to know kind of the standardization of how to report it on endoscopy. We'll see the circumferential margin maybe 6 centimeters from the G junction, like in this diagram. And then the maximal extent, there may be one little tongue that comes up a couple centimeters more. So you'll report the C as the circumferential and then the maximum. This will help with just how we go about communicating to each other between GIs and surgeons about Barrett's disease. But as we know, and what has been highlighted already, is that there's limitations for not only once we see Barrett's, okay, yeah, you saw it, you wrote it, you wrote down how extensive it is, But then what do we do from there? What do we do with those patients? How are we going to screen them? We know that the incidence of esophageal cancer is increasing, and Barrett's is the precursor, and yet we don't have protocols for the population-based recommendations for screening patients. And EGD is expensive, so that tends to lead questions of who to screen and when to screen. So there's a lot of companies out that are coming up with new ways or better ways to help screen the population at baseline. How do we do that if patients can't get an endoscopy because that's too expensive to screen the entire population? And then with the patients with Barrett's, how do we predict who's going to go on to get esophageal cancer? How are we going to better diagnose dysplasia and metaplasia and kind of classify them with their Barrett's to know their true risk? Watts is a great adjunct to the Seattle protocol, but what else can we do? Well, the cytosponge is a very interesting idea, and it's actually, one of those, it's a population-based screening tool without endoscopy. The cytosponge is a small little capsule that can be swallowed by the patient, either usually in a clinical setting. It expands like a grow-a-sponge, like when you were little and you put the sponge in water, and it grows inside the stomach. And then it's connected to a little string that you can pull out, and it scrapes the inside of the esophagus to give cells for pathology. It's easy, it's non-invasive, it's affordable screening test. Basically how they then analyze the cells for this trefoil factor 3, which is one of those factors that's seen in Barrett's. The sensitivity and specificity for this is good. So this is a video of how this cytosponge works, and hopefully it will play. There we go.
The cytosponge test is a simple solution for collecting cells from your esophagus, food pipe.
Enjoy the British accent.
This innovative solution uses a small capsule-shaped device the size of a multivitamin pill. A thin string is connected to a sponge inside the capsule. When you swallow it with water, the capsule dissolves and the sponge expands in your stomach. The string is then gently pulled to retract the sponge. As it's retracted, the sponge collects cells from the entire length of your esophagus. Cytosponge, a simple solution for collecting esophageal cells.
So that's the overview. I think this would be great because most of the patients that we're screening or that we're seeing in endoscopy are the patients that have a GI doctor that complain to their PCP. And I think a lot of the population is missed because acid reflux is such a common problem, and there's so much ability to self-medicate that patients may have chronic acid reflux and don't even think that it's a disease that needs a clinician's help to treat. They'll self-treat. So this would be something that could be done in a PCP's office. I think it's an exciting innovation. I don't know how it feels necessarily. I haven't done it myself, but I think that would be a limiting factor, is how uncomfortable it could or may not be. This is not commercially available in the United States yet, though. They've done testing in the UK, but it's not commercially available in the US. But this is one of those things that if we could get to the population may help with screening. So other imaging modalities, now we're going to switch gears a little bit to the patients that we know have Barrett's, and yet we're missing the patients that are going on to get esophageal cancer. So what do we have in our toolbox to help us kind of treat the patients that we know already have Barrett's, besides the Seattle protocol, besides just biopsies? The one thing that Prakash mentioned already was NBI. This is kind of part of your standard endoscopy and screening for Barrett's. It's done during an endoscopy. Most endoscopes have NBI available by the click of a button. So this really should be part of the standard protocol. Basically, it filters within the endoscope to emit a certain wavelength of light to visualize the mucosal patterns and highlight the mucosal patterns a little bit better, so that we can look for areas of metaplasia or evidence of dysplasia and help guide our biopsies a little bit to the high yield areas. It's about 90% sensitive and specific. It's easy, it's click of the button. I think most endoscopists are very comfortable with narrowband imaging, and this is, I think, used routinely. It can help pick up metaplasia versus high-grade dysplasia. Intestinal metaplasia will look like fine capillary patterns with this ridged or villous pattern, and high-grade dysplasia and even intestinal neoplasms have increased capillaries with tortuosity in a dilated or corkscrew pattern. So these are just some examples of how you can use MBI to pick up areas that are high risk. There's other imaging modalities out there, so the next one I'm going to talk about is CellVisio. So CellVisio is kind of like a probe. It goes through the scope. It's a through the scope probe that can visualize the mucosal areas up to 150 microns deep, which is the area where you'd find Barrett's. And like Prakash said, that's where those crypts are, and that's where we can really see dysplasia. So it can visualize those areas and give us a better, it almost gives us a histologic image without sending tissue to pathology. So we can see that endoscopically, that histologic pattern endoscopically. You do have to give IV fluorescein or some kind of dye in order for this to work. And it's highly sensitive and specific. Here's some pictures of kind of how that works. It's a through scope probe. And then on the endoscopic image, you focus the probe on the areas of the Barrett's where you want to look. And in the bottom picture, you see that histologic pattern. You can see it enhances, allows us to almost be a pathologist during the endoscopy. Here's some examples of the images you could see and kind of the patterns that would alert you to pick up metaplasia or high-grade dysplasia. The normal, A is normal. B, in that picture, we see some intestinal metaplasia, enhanced nuclei, and some of that enhanced pattern of metaplasia. And then Barrett's esophagus on the far, the right side of the screen. The other thing that's nice about this technology is that it can be used in the esophagus, it could be used in the stomach, and it's even been used in the bile ducts, like ERCP. So it's very versatile at looking at this histologic picture, and it can even pick up H. pylori, for example, in the stomach. You can see in these pictures, they're saying these little white bright dots is H. pylori, and it correlates to the pathologic staining at the top. You can pick up not only that they're present, but then also how much of it is present in the load of H. pylori. This is a very interesting imaging modality, and it does help us see that histologic pattern, but you have to know what you're looking at. And I think that's been kind of the limitation to this modality, is that you have to have training. You need intense training to know. You can see those pictures and see the histology, but you almost have to understand, like a pathologist, what you're looking at. It does survey high-risk patients. So where I think this could be useful is in clinicians that are specializing in Barrett's and treating those patients. And we need screening to see if there's some high-grade dysplasia or concerning areas, I think this could help. It can guide biopsies to more suspicious areas. So we can, if we learn those histologic patterns, it helps target very high risk patterns, and it can also help guide EMR. So if you find an area of high grade dysplasia that maybe indicate you could do EMR for, this can actually help not only find the margins of where you need to resect, but also determine the feasibility of EMR. I said at the beginning, it was only 150 microns. So if you see that the distortion going deeper than that area, then maybe this patient is not an EMR candidate at all and would have to go to a surgical intervention or have some other modality. So I think there's limitations, but I also think that this could be very helpful in the right hands. It takes some time and training, but I think when used right, this could definitely be a benefit. 9-point is another one of these types of modalities that can help endoscopically visualize tissue. This is more like endoscopic ultrasound. It's quickly obtains cross-sectional area and longitudinal images and shows irregularities within the mucosa. It has a very interactive user face, so you can kind of scroll up and down on the screen. It's a touch screen. And it can also mark targeted areas. And I have a video that shows what this looks like. This doesn't have video, so or sound, so I'll kind of talk over it. But you have this joystick. This is your navigational pad, as it says, and then a laser trigger, and that's used to burn or mark areas that look concerning. So you have some kind of indication on the mucosa of where that area is. Through the scope, you place this balloon that you then inflate in the esophagus. And then you have this imaging probe. You can see in the video, it's spinning and it's traveling up the esophagus and taking these cross-sectional images of the esophagus. And this is what it kind of plays out to. So now we see the cross-sectional images as we go along, spanning the whole area of Barrett's, and then there's an irregularity there in the mucosa that we can target, and you can press the button to make these little burn marks, and that can show you the border of where that irregularity is. I feel like this, it's so this modality in the studies that I looked at had some inter-observer variability is high as far as what you're looking at and deciding what is irregular and what's not. There is again, training and skill is required in interpretation. It's similar to EUS. So you have to have that skill in interpreting what you're seeing, similar to that of ultrasound. It is expensive, and the other drawback is it's not very versatile. So Cellvizio you could use in the esophagus, you could use in the stomach, bile ducts. This is a balloon. It's really tailored to the esophagus. And so that's been one of the criticisms of this imaging modality, is that it's almost too niche. But for Barrett's, if we're talking about Barrett's, I actually think it's a really nice platform. I think it's a little bit easier to use and pick up those abnormalities in the mucosa than seeing a histologic pattern necessarily. And then I really think it's useful again for EMR. You can mark those areas, the borders of their irregularity. So if you're going to resect that area of Barrett's or that nodular Barrett's, you can resect that at that time. Again, you could target biopsies and maybe pick up more high-grade dysplasia than you would if you're just doing random biopsies of the whole area of Barrett's as well. The last modality I'm going to talk about is TissueCypher. So this is not an imaging modality. This is kind of trying to answer that question. Okay, we've got a patient with Barrett's, maybe even some dysplasia or metaplasia, and we want to know what is their risk of progression to esophageal cancer, because we know it's not there's a slow progression, and we know that not everyone progresses from Barrett's to esophageal cancer, and that risk seems to be different from patient to patient. And so TissueCypher, as the picture kind of shows, it's trying to be the crystal ball for us. It uses forceps biopsies specimens, so the specimens that you're obtaining anyway for the Seattle protocol, and you can send them out to this the lab, the TissueCypher lab, and it can predict the risk of Barrett's progression to either dysplasia or adenocarcinoma. It measures a combination of epithelial, immune cells, stromal processes in the biopsy to produce this risk class. And it gives you a high, medium, or low risk of progression. And so that may help you tailor your surveillance protocols to, okay, this patient may not need an endoscopy every year. Maybe they can go 3 years if they're on the very low risk group versus the high risk group. You may want to resect that area of high risk tissue. The sensitivity for this in the high risk group was pretty low, but the specificity was high. So they're, they have a little bit of work to do, I think, as far as like getting their risk algorithm to be as accurate as it can be. But these are some of the examples of the staining that they do. They do multiple staining. They use AI as well. It's not just, they put it through a whole AI and pathologist type of a screening protocol to come up with this risk. I think we all know that there is a challenge of determining who's going to progress. We need, as clinicians, I think we need better ways to not only identify Barrett's and catch more patients earlier on with Barrett's esophagus, but then once we do, I don't think our screening mechanisms are good enough. Screening every 3 years, we miss patients, or even if we're very diligent and we're doing the Seattle protocol, there's so many areas within that area. If we're just doing random biopsies, we're missing. So all these imaging modalities are there to help us find those high risk areas and be able to intervene earlier so that we don't have so many patients going on to esophageal cancer. I think in combination, if we can, I think the modalities that I've talked about, I think the send out lab is easy. That one is just, you're doing the Seattle protocol anyway. You can send this lab out to kind of get a risk score to understand who may be higher risk in your patients, and you may screen them more often or intervene in a more aggressive way. I think the other two modalities, the 9-point and Cellvizio, I think are really good for those high risk patients, like in the males in their 50s, that long chronic GERD that have long segment Barrett's, to really do a good screening. I don't think that's going to be part of your every clinician's day-to-day protocol because of the time constraints. But I think for screening for high risk patients, those come in really handy. And I think those should be included in centers that are taking care of Barrett's patients, at least one of the two. That's all I had for you. That's what's on the horizon. I think it'll really help us as clinicians combat both Barrett's and the progression to esophageal cancer. Thank you.
Thank you so much, Dr. Houghton and Dr. Gata. That was wonderful. And we are on time, so we have about 20 minutes to go through some questions and discussions about aspects in using these techniques in clinical practice. I'll ask those questions first, which were posted on the Q&A section from Dr. Adam Chvisco. His question is to Dr. Gata. He says, what is the influence of PPIs on Watts 3D results? Should PPI be stopped before Seattle protocol or Watts?
That's a great question. So I was thinking about this. First of all, I thought I didn't know the answer, but then if you think about it, if you have a patient that comes in underdiagnosed or presenting for the first time with reflux disease, you get an endoscopy and the patient has severe erosive esophagitis, like grade C or D, Los Angeles grade. Typically what you would do is treat those patients because you can't biopsy them right now or biopsy them in an effective way to rule out Barrett's esophagitis. So you typically put those patients on 2 to 3 months of PPIs and bring them back. So I would expect that a lot of patients who do get Seattle protocol or Watts biopsies are actually on chronic PPI therapy because these are symptomatic patients. I would also submit that I believe all of the studies and the effectiveness of both the protocol Seattle versus Watts are probably patients who have had chronic changes from being on PPIs chronically. I don't think it affects the efficacy or sort of yield in a negative way. I think that's just the disease set. Dr. Houghton, do you think any differently?
No, I agree with you. I think most patients that we're biopsying with Seattle and Watts are on chronic PPI therapy to treat their disease. So I think most of those patients, and it shouldn't affect it.
Yeah. And if at all it should help, as we often get this indeterminate for dysplasia patients who are basically untreated reflux injury, which kind of muddles the results. Therefore, I think I agree, as both the panelists said, continue them on PPIs or treat their reflux well before biopsying, just to get a clearer picture. Perfect. Next question from Anonymous for Dr. Houghton. Since Cytosponge is not commercially available in the United States, have we considered EsoGuard or EsoCheck, which is a silicone balloon that is commercially available in the United States and has more than 91% sensitivity and specificity?
Mm-hmm. It's probably bad of me to admit this, but I don't know of that modality. Prakash, do you, or Dr. Chandra, have you have any experience with it?
Yeah, I'm sure I don't know as much as Dr. Chandra does, but I have seen, to me, EsoGuard appears to be, what's the protocol used for stool screening, like, the DNA, or you look at blood? I think it's a similar mechanism. It seems to make a lot of sense, especially if the cost is lower, there's no sort of procedure cost, and sensitivity is high. What do you think, Dr. Chandra?
So I have some experience, including trying to swallow one and did it successfully. EsoCheck is the sample collection part of it, and EsoGuard is the patented technology to detect dysplasia or Barrett's metaplasia. To be frank, it was a challenge, and we were part of this LUCID trial. And out of 8 people whom we needed for volunteering to be part of the site, only 3 of them could swallow it. So it has a thick catheter, and that kind of catheter gets stuck to your tongue. And to be frank, that was our experience. So the swallowing is the bigger challenge. Now, those people who are not aware of EsoCheck, it does have advantage of not scraping your throat because you basically put the catheter with the balloon into the stomach, inflate it, pull 5 centimeters, and deflate it. So kind of it's invert inside, so you don't scrape rest of the esophagus. So all the problems of Cytosponge, like getting gastricardia mucosa, still persist with EsoCheck, but does not scratch the throat. But the other thing I learned that when you scratch your GE junction, you can still feel in the throat. So if somebody says dysphagia below the sternal notch means esophagus, that's not true. Anyway, EsoCheck has a good chance. Currently, it's available, and I think primary care doctor's office is the best place. We are planning to have it probably with our manometry lab, because those nurses have experience in making patients swallow the Bravo capsule or the manometric catheter. So that's administering it's a challenge, and you probably need a lab, and you don't get much out as a GI practitioner. So primary care doctor through the manometry lab is the way to go, I guess. Okay, our next question by Dr. Fanes. What happens if biopsies versus warts produce conflicting results?
Can I answer that? So I was thinking that, so the whole point of Watts is the yield is higher. So if for example, the same patient had Seattle protocol once and then Watts the second time, I would think with the yield of the Watts as being higher, you would obviously gravitate towards the abnormal results on the Watts. So what I'm saying is the false negative rate is probably higher in the Seattle protocol. So if there is a disparity between the two biopsy techniques, I would obviously go with whichever one shows abnormality, even if it's Seattle protocol and the Watts was negative. So I would treat that as I'd be more concerned about the abnormal finding no matter what it was.
Yeah.
Right.
I agree. I've had that situation. We usually would do the Watts and biopsy actually on the same patient. So we would do the Watts brush and then we would take some biopsies as well. And I found that if there was going to be even Barrett's found or any kind of dysplasia, it was more often seen on the Watts than it was on the forceps biopsy. Dr. Chandra,
that's consistent with our overall Barrett's management. You always make a decision based on the worst possible or worst histology detected. So if patient has high-grade dysplasia once and the next time has low-grade, you treat them like high-grade. So that's consistent with the overall approach in Barrett's esophagus. I have a couple of more questions, and these questions are for both Dr. Gutta and Dr. Houghton. About the warts. In your clinical practice, who is the patient you're using? Are you using for surveilling a long segment Barrett's esophagus, or screening for people who have irregular Z-line, or looking for recurrence of metaplasia in a person who has Barrett's eradicated?
So the question is who is the target for Watts?
Yes.
Yeah. So first of all, since I do far less diagnosing of the disease, having a surgical specialty, this is a question that thankfully I don't have to answer often. But I would say that I think when you think about inter-observer variability, so I think the sort of irregular Z-line as a trigger to do more aggressive, treatment or workup, I don't think is very reliable. I think the long segment Barrett's obviously would be the subset of patients that, as Caitlin had described, the sort of 50-year-old white male with long segment Barrett's, long-standing history of reflux, smoking, high risk factors, etc., would be the primary target. Now, I think we here in a society like this, if there are recommendations being made to Medicare, for example, as to who the screening should be done on first, as we have for colonoscopy screening, familial history, that would be that ideal subset of patient where you would have Medicare or a payer pay for screening. I don't know what you think, Dr. Chandra, but if you are 45, you're getting a screening colonoscopy, I don't believe the cost of an upper endoscopy at the same time is significantly higher as opposed to two separate visits. So, I think in terms of a cost perspective for screening, I would select the subset of patients with a prior history, a chronic history of reflux, all the risk factors, prior history of metaplasia, patients, for example, who've had prior anti-reflux disease and are still showing symptoms or evidence of esophagitis or metaplasia or Barrett's.
Agree. I also happen to believe that, or agree with the findings that we only detect 50% of esophageal cancer if we go by long-standing GERD and risk factors based strategy for screening for Barrett's. So it's one way to go about it, but it's far from perfect.
Yeah, I think Watts, we do surveillance on some Barrett's patients, and I think I don't necessarily do it at the index procedure. If I'm doing, let's say I'm doing a workup for GERD for a hiatal hernia or something, and we're doing an endoscopy. If I see long segment Barrett's, or if I see a significant tongue of mucosa, I think Watts is a good way to go. And then I think anyone that's being surveyed for Barrett's esophagus, I think Watts is a good adjunct because it gets the deeper tissue, and it also gets a wider cell base. So the forceps biopsies, I feel like you can miss things, and the Watts gives you a better just sampling more of the tissue. So I don't think it's good. I don't necessarily think for just an irregular Z line necessarily though, because I think that you know, that may give you false negatives, I guess.
I'll talk.
Or false positives, sorry.
Agree. Yeah, that's what Watts groups would like us to use them for, but I agree, it's long segment Barrett's in whom you are trying to minimize the risk of progression to dysplasia or cancer with the right person. Another question regarding how to use Watts brush. If you can share a couple of tips on, do you use the brush to go back and forth? Do you use the whole scope to go back and forth? What would you take care about if patient has a hiatal hernia? Any bad incidents which we should watch out for?
I think Caitlin should answer that because having done zero.
Okay, yeah. So I think that Watts with a hiatal hernia, well, or even like a dilated esophagus is a little more difficult. Sometimes the angulation of the valve can just make it a little more difficult to get the cells that you want and get the scraping of the brush against the mucosa the way you want it. So there's so many variability in this. I tend to use the brush and go back and forth because I don't like my scope like going in and out of the mouth and scraping the whole length of the esophagus. So I tend to use the brush, but I know some of my partners like use the scope a little bit more. I like using the brush. I think you should be the one, the surgeon should be the one, or the endoscopist should be the one manipulating the brush instead of having your tech help you type of thing, because you can have a better eye. And I think we're a bit more careful. So those would be my tips. I think just watching the tip of it. I like using the brush because I think it's more controlled, and having whoever is doing the procedure actually control the Watts rather than having someone assist you with that.
Yep, that makes sense because the animation always looks easy, but when you do it, by the time you have finished your Seattle protocol, you already have everything bloody and visibility is not the best anymore, and being careful is helpful. Well, those were the questions I had. If you guys would like to share any more insight about Cellvizio, can we mark the site from Cellvizio? Is there a marker like you have in?
Okay, so we're gonna stop here. So we had this interesting presentation of the Barrett's esophagus. It is basically a representation of GERD, gastroesophageal reflux disorder. So first, as we saw for that video animation, it's Barrett's esophagus that is the first stage of esophageal cancer. And if it's not discovered in time, it leads eventually to the cancer, and then mortality is much higher. Chance of living beyond 2 years or something often is not just there. So modern medicine then looks through, and modern TCM also looks through scoping to when patients complaints of, let's say, what we call stomach tube rebelliously moving upward, they would scope it. And so the question is now, do you have sensitive enough endoscopic equipment that can pick up Barrett's esophagus, take a sample, and then maybe get a sense that this is precancerous, and then of course treat it before it turns into cancerous. So boosting our Vital Qi, Zheng Qi, and others. So clearly we don't have access to this in the West, but our colleagues in China have. So let's have a short break, and then we're going to continue looking at another video. Thank you. Okay, so we have looked at medical information about esophageal cancer. We looked at the TCM treatment of esophageal cancer. We looked at diagnostic procedures, mostly through endoscopy. And so we're going to look at the surgical and endoscopic approach to treatment. And so this is what we usually inherit when the patient comes to us here in the Western Ontario. So patients are often treated endoscopically, and then we end up supporting them through post-operatively. So here's the link. So let's have a look at how that looks. So it gives us a better understanding what our role is like post-surgically in treatment of esophageal cancer.
Okay, well, good evening, everyone, and it's a real privilege to be here with you tonight. And we're going to speak to you today about endoscopic and surgical approaches for esophageal cancer. My name is Raman Muthuswamy, and I'm the medical director for endoscopy at UCLA Health. And it's a real privilege and honor to be doing this session with my colleague, Dr. Paul Tosti, who's in our division of thoracic surgery, and I'm going to kind of present the endoscopic side, and he's going to tell you the latest from the surgical side. And clearly, this is a disease that is multidisciplinary and really requires the full breadth of options. And hopefully tonight we're going to try to provide you with an up-to-date summary of that. So with that, I'll get started. So I think from an endoscopic standpoint, there are three quick questions. First of all, can we reliably identify appropriate candidates for endoscopic therapy? When I was a medical student, I heard this said, well, 40% of the time it's high grade, there's going to be cancer in the surgical specimen. That's why you can't treat high grade endoscopically. Is that still true? I will say that that data was from the 70s, so it's about 50 years old now. And so can we really identify the appropriate candidates? Two, if you can identify them, do you have something that you can do that actually works? Okay, what do we do right now? And then three, are these methods actually durable, and are the outcomes comparable to surgery? And I think we have to answer yes to all three of these questions if we're going to provide endoscopic therapy. And I would argue happily in 2021, and frankly, for probably about a decade now, the answers have been yes. Okay, so in the course of my talk today, I'm going to talk to you about the tools we use to select appropriate candidates, the techniques we use to treat them, primarily mucosal resection and endoscopic ablation, and then lastly, we'll compare some outcomes and our current best practices before we conclude. So you all know esophageal cancer is increasing. It's the most rapid adenocarcinoma of the esophagus is the fastest rising cancer in the US. And now we have a total of about 15,000, 17,000 a year. And what's changed is that we now have more adeno than squamous. And here you can see that the projections are that we're going to approach, close to 50. I don't think we're quite at that level all comers, but it's certainly increasing. This is a slide that was produced a few years ago. Esophageal cancer, however, still presents late, unfortunately. Most patients present with dysphagia. Usually when they have dysphagia, they're usually at least T3. And the overall survival is around 17% at 5 years. And it's unfortunately associated with early lymph node metastases, which is why many patients usually present with advanced disease or frankly unresectable. And as I mentioned, we've now gotten to a point where adenocarcinoma is more common than squamous. And even though we're doing a lot of Barrett surveillance, we haven't really moved the needle that much with regards to improved outcomes. And I think we probably ultimately need to screen better. So the first thing that we need to say is, can we assess Barrett's and identify, patients with invasive cancer? And so the photo on the left is somebody who is kind of a modern image. You can see more high def imaging, and this is more a standard white light on the right. It's kind of a new TV, old TV. You can just get much more detail, and I'll sort of show that in the coming slides here. Again, we can also, in addition to standard imaging with high definition white light, we can also use chromoendoscopy. So we can use stains like methylene blue to highlight areas of dysplasia within glandular tissue. And we can also use Lugol's, which beautifully highlights squamous tissue, and cold spots within Lugol's can identify squamous dysplasia. in patients, and it can really quite striking. So here's a patient I just did literally in the last month. So again, you don't see a whole lot here. You might say that I can see a little white here, but then when you use the Lugol's, you can see these cold spots, and I can tell you these were all high-grade squamous dysplasia here that we ended up undergoing treatment for. So again, the stains though are a little bit cumbersome. They take some time. It'd be great if you could just press a button and get a real-time, on-demand capability. Look at vasculature. Look at the careful mucosa, and it'd be a lot less messy and time-consuming than sort of this spray chromoendoscopy. And we actually have that in most of your scopes. And again, we have this optical chromoendoscopy that uses a filtering of white light, or sometimes uses software image processing to make these changes. So narrowband imaging is very commonly used. It uses blue or green light. Blue light is reflected more superficially and sort of makes capillaries brown. Green light is reflected deeper and sort of takes sort of subepithelial vessels and make them sort of a cyan color. And you can see on the right, top right here, what I'm talking about. These are brown sort of surface capillaries. And then you can see sort of the deeper cyan sort of subepithelial vessels. And you can use this to sort of assess the organization of the vessels to determine if they're irregular or irregular, to help determine if there's abnormal tissue there or not. So a group of experts got together, this Barrett's International Neoplasia Group, and they ended up subsequently coming up with some criteria that looked at the mucosa and the vascular patterns and classified them as regular or irregular. So they kind of give them a fairly easy binary sort of thing. Is it regular or irregular? And they kind of showed them what they were looking for. And you can see some pictures here. And I always tell our fellows it's kind of like being on an airplane flying over a suburb and looking at how the subdivisions are well organized. And so they all kind of look the same. You're probably looking at normal. And if each one looks different than the other areas, some look small, some look big, this is the areas of regularity. And usually the areas that are enlarged are the ones that are usually irregular. So you also want to look for vascular patterns and, of course, surface topography changes. So when they gave these folks this regular, irregular, and then asked them to sort of classify, they actually turned out they were pretty accurate, about 85% accurate for detecting whether there was dysplasia present or not. And when they said they were high confidence, they were really good, 92, and then when at low confidence, they were still okay, but they went down to 74%. And the sensitivity was quite high again when there was high confidence in these things. So there is value in this. And so this, in addition to just better high definition imaging, chromoendoscopy, whether it be optical or spray, can help. Now, the third thing we use is endoscopic ultrasound. Now, endoscopic ultrasound is really mostly used today to look for whether a lesion is gone through the wall or it is associated with lymph nodes. It's not that useful to separate between T1A, T1B. That seems to be a little bit too nuanced, and we pretty much use either injection or EMR to figure that out. So again, this is just you use these ultrasound waves to look through the wall. Submucosa, if it goes in one area, it's T2. If it penetrates through the wall, it's T3. And if it goes into an adjacent structure, it's T4. And of course, lymph nodes, positive or negative N0 or N1, and N0 obviously if it's negative, and N1 if it's positive. So here's some pictures of things that are based just on the surface. This one's a little deeper in the wall, but not through. And I'll show you some better pictures here. Here's a tumor that went through the wall and was touching the aorta. So again, here's a lesion. It doesn't look that impressive, but it's mostly submucosal, but the outer wall is actually intact. So this is actually a T2 lesion because the outside walls, and this is actually a patient who would be not appropriate for endoscopic therapy, but would be actually a good surgical candidate. Now here's a patient which looks like a bigger lesion, and sure enough, this is actually a lesion that goes deeper into the wall, through the wall, and is actually, fortunately, not into the aorta, so it looks like a T3 because there's no local. So this would be someone you typically downstage and then operate on, hopefully with response. Now here's a patient that I had that had a big tumor and you can see this inflammatory change, and there's no separation of the fat plane of the aorta with this, and this we call the T4. Here's another patient that has a mass extending right to the pleural space of the lung, which is that bright white line suggesting pulmonary direct spread T4. Why does all this T stuff matter? Well, it turns out that the depth in the wall is critical to determining the amount of risk for lymph node metastases. And I started off by telling you part of the problem with esophageal cancer is it's associated with a high rate of lymph node metastasis. So things that are based just in the epithelium have essentially no risk of lymph node metastasis. If you go into lamina propria, it's maybe 2%. In the muscularis mucosa, maybe 7%. And so this area here, anything north or sort of more superficial to the submucosa, these are ideal candidates for endoscopic therapy. Once you start getting into the submucosa, whether it's the proximal third, the middle third, or the lower third, your overall risk of lymph node metastases is about 25%. I'll come back to this issue. There's some controversy now about whether a subset of SM1 patients, primarily those who refuse surgery or poor surgical candidates, may be able to be managed endoscopically. So there's some research into that now. Now here's the risk of lymph node metastases based on submucosal involvement. You can see it's 26% overall for adeno. It's even higher for squamous. Now for SM1, it's only 10% for adeno, but it's 27% for squamous. So again, you have to be very careful with endoscopic therapy of squamous lesions because of the substantial risk of even early stage lesions having lymph node metastases. Here you can see SM2 goes to 21% and 49% for adeno. So it's important to look at these features and kind of understand them when you're trying to decide what you're going to do. I told you we look for the EUS for malignant lymph nodes. What are we looking for? We're looking for a big black circular node, something more than a centimeter, something next to the tumor, something that's homogeneous throughout, so it's dark and doesn't have light areas in it, something that looks like it has sharp borders and is circular as opposed to triangular or regular borders. These are all the four common characteristics, and if all four of these are present, at least in esophageal cancer, there's probably about an 80% chance that it is malignant. Now, in the old days, when this paper was published, that alone was enough to call it, but of course, for the past 20 years or so, we would just stick this needle in this node if we needed to. Now, obviously, if you have a T3 lesion and you find a node, you're already headed down the neoadjuvant path anyway, so you probably wouldn't FNA it. Again, here's an example of what we do. If we do find a node that we think is malignant and it would change management, we can go through the wall of the esophagus and biopsy this. And it increases the nodal staging accuracy over not doing this. So in other words, if you describe it versus you stick it, you get about a 20-25% increase in accuracy, which is not surprising. So we do this. Now, we don't do it when it doesn't make a difference. So you already got disease that it's not going to change your management then. But if you have a T1 or a T2 with a lymph node, then it would make a difference, because if the node was positive, you wouldn't elect to do endoscopic or surgical therapy up front. So here's some more examples. Here's a patient who had a celiac node that had a mid-esophageal tumor. So this was sort of a somewhat regional sort of MET. And then here's a patient who had two big, chunky sort of periceliac nodes that were almost perigastric that we're seeing here. But I will tell you, to go back to what I started with, is do you really have that many patients today that have high grade that end up having a ton of cancer in the operating room? This goes back over 20 years at the Brigham, and what they found was that in the patients they had 41 patients they operated on with high grade, and they only had 6% of them that actually had submucosal cancer. So really, we were doing much better. And I would argue that this goes back from 87 to 07. I would argue this number should be close to zero in 2021 with the tools we have. So let's move to the next thing. Okay, so maybe you can identify the patients. What are you going to do with that information? So endoscopic mucosal resection, we've got submucosal dissection, we've got RFA, cryotherapy. So we can cut it a couple of different ways. We can burn it, we can freeze it. I'm going to talk about the ones that are most used. Usually now we basically suck it up like with a bander. We put a rubber band which provides protection from getting a deep muscle injury or a perf. And then you can even cut below the band. You don't have to cut above the band. And this is very highly efficacious. You can see that you can do multiple of these and connect them and get large areas. Each specimen is usually 1 to 1.5 centimeters, but sometimes up to 2 centimeters. And when you take these large chunks rather than biopsy, you can change the surface biopsy diagnosis in about 45% of cases. So it's important. And again, I've kind of covered this, but again, the depth of invasion determines your risk for lymph node metastases, which is why it's critical to know the depth of invasion to determine if endoscopic therapy will be adequate. You can sometimes inject, but you don't typically need to. You can typically just place the band and cut below it. And I'll show you again, this aids in both getting you a specimen, but you've now also removed the abnormal tissue. So it is a form of therapy as well. And again, here you can see this abnormal area, and subsequently with EMR times 2, it's been eradicated. So again, here's a short video that kind of highlights a little bit of this in my limited time here. I'll sort of slide forward, but we put the band on already, and then you just kind of bring the snare underneath, and then you sort of can grab it and pull it up and cut it. And you can repeat this. You can do this 6 times because you've got multiple rubber bands. You typically want to pull away to make sure there's no muscle that's grabbed, but your best friend is the band here because that'll help sort of avoid you getting a full thickness. And then you sort of just cut this out, and then you can literally, I just usually just suck the piece right into the cap and submit it. So there we go. And then there's our defect here. And I'll just kind of slide forward here to kind of what it looks like perhaps at the end. So there's the defect. You can assess it. You can do multiple. So here's one where we've sort of added the 2 together to create a nice confluent defect. And then you can suck up the pieces like I was telling you this way. And subsequently, you can look at the overall defect here, and you can see that you've removed this area of tissue. So this is kind of how we do this. When should you do this? Anytime you see a visible abnormality, whether it's raised, if it's depressed, as long as you can lift it safely. And you can sometimes consider injection if you're worried that it won't lift. And then again, less than 20 millimeter lesions can be removed in one piece. Larger lesions can be resected piecemeal. And the early studies comparing ESD to EMR suggest they're comparable in oncologic efficacy, but the ESD is technically more difficult, takes longer, more complications. And it's really hard to resect the muscularis propria. So you shouldn't be afraid to do this. So some people said, well, gee, if you can do this, why not you just resect all the Barrett's? Just take all the nodules, take everything. And you can do that, but you get an 88% stricture rate. And so anytime you do about more than 2/3 of the circumference with EMR, you're going to get strictures, and they can be difficult. And then you end up spending a ton of time treating the strictures. So it might be better to EMR just the focal nodules and then ablate the rest. And again, there was a randomized trial of ESD compared to EMR, and as I mentioned, there's no difference in complete remission of the dysplasia, but there were 2 adverse events in the ESD group. And it was interesting, there was 1 recurrence and occurred in the ESD group. Now, my partner, Ali Setarad, does do ESD. Here's a patient with diffuse squamous dysplasia. He's marked sort of areas of this. He's done a broad sort of ESD, and he kind of just kept going. This is what it looked like. He actually did a circumferential ESD, and then this is that patient just recently. And he actually resected almost the entire length of the esophagus circumferentially. So it's really an amazing photo that he did. And you know, again, he wanted to make sure that there was no deep invasion anywhere, and unfortunately for this patient, there wasn't. But so this is the level of techniques we have. We just have to choose which one when appropriate. So what about ablation? You can either burn it, freeze it, or you can use this hybrid APC. Burning it with radiofrequency ablation is by far the most commonly used. New England Journal data, JAMA publications, multiple RCTs. Works at least 80% of the time in getting rid of all the Barrett's and all the dysplasia 90%. Typically, you see adverse events in 5 to 7%, usually strictures. And again, recurrence can occur in about 13% overall, so you do require long-term surveillance. Here's what it looks like to ablate before and after. You kind of desquamate the tissue, and you can see how you can convert an area of Barrett's to normal tissue over here. And you can use this for squamous dysplasia as well, but you really just want to make sure you're not dealing with squamous cancer. So I think, but there's evidence that's been done that RF is highly effective in squamous cell cancer. Cryoablation can be done either through a balloon using nitrous oxide or using liquid nitrogen. which requires a decompression tube because it expands and can lead to gaseous distension. And these techniques are showed that they're about 80 to 90% effective in dysplasia eradication and early cancer, but they don't get rid of all the Barrett's tissue, particularly the liquid nitrogen. So that's why RF has sort of taken a primary role over this. And you can see it's kind of fun to do. It's literally cool, as they say. You can freeze right here. Again, the idea is that the depth of the injury is determined by how long you freeze it for. If you go for a minute, you'll get transmural sometimes. So usually we do, between 10 and 20 seconds, sometimes 30. And how many times you hold it frozen. And it's usually between 3 and 4 sprays. And so you kind of freeze thaw. And, this is usually about a 20-minute procedure. So they're actually time efficient. So again, here's a still photo of an area. You freeze it. You've now frozen. You let it thaw. You hit it again a couple more times. And you can treat about 2 centimeters at a time with a spray hemicircumferentially. So the new thing on the block is hybrid APC, where you inject underneath an area of tissue and use APC. APC certainly is sort of low cost compared to some of these other things, but it does tend to get a little deeper, which is why you need to put this liquid in to avoid the rate of stricturing and or deep tissue injury. So still not quite ready for prime time, I think, but it is a third option. Here's an example of us kind of putting it all together. Here we've got a patient who's got a little bit of a nodule, some flat Barrett's. So we went ahead and EMR'd the nodule after doing an ultrasound showing that it was really confined to the surface layers. We resected that nodule in one piece, and we got the path report we wanted, which is that it was a cancer, but it was in the lamina propria and the muscularis mucosa, T1A. And I told you that means that there's a 7% or less chance of lymph node metastases. Submucosal tissue was present and there was no tumor there. And importantly, the deep and lateral margins were negative by 0.8 and 2 millimeters, and there was no lymphovascular invasion. So this is what you want every EMR to read like. And of course, this patient has done well. 3 years out, have had no recurrence, is doing well. And this is a nice success story. As I mentioned, there's a risk of recurrence that can be overall about 13%. And so the one downside to endoscopic therapy is there's going to be at least 5 years worth of surveillance and perhaps most likely even longer. So they don't get to stop endoscopy, and that issue does exist. So the last few minutes I have, I'll talk about long-term follow-up. We have, again, data showing this is 1,000 EMRs that were done in Europe, and they had a 96.3% complete local remission. And during follow-up, which was here almost 5 years, they maintained remission in 94% of those patients, which is really quite impressive, and that was at 5 years. Here's another study that had not quite the same level of follow-up, that used a combination of resection of nodules, ablation with RFA of flat Barrett's, and they were able to get rid of all neoplasia in 98% and all of the Barrett's in 93%. And over 2.5 years, they had very low rates of neoplasia recurrence, only 4%, and any Barrett's at 8%. So it is important to know that there can be recurrence, but it can be kept at a fairly low level. So I'll close by talking about what we should do now. And these are some quality metrics on this. This is an area of my interest, and 2 colleagues and I came up with a set of metrics which are now used by the ACG and the ASGE, excuse me. So here's the quality metrics for performing the procedure. That you should have a dysplasia diagnosis made by a pathologist or confirmed by a second pathologist. That centers should be able to do both EMR and ablation, not just one or the other, and that you have to make sure you confirm that there's pathology present. In terms of performing this, again, we need to document the length of the Barrett's. We need to identify visible lesions, which we can do with the high definition scopes we have, and that they should be used. And that we should resect lesions ideally en bloc, or at least in pieces in patients with visible lesions. And again, we should make sure we follow these patients up closely until all of their Barrett's is gone, and that you should at least get rid of all of the neoplasia in 80% and all the Barrett's in 70% within 1.5 years of starting. So you do have some benchmarks, and then post-procedure, you have to follow them because I told you it can recur at about 13%. And again, you should biopsy visible abnormalities you see during follow-up. Recurrence is related to lack of acid control, or reflux control. So an anti-reflux regimen is recommended. And of course, you should track your adverse events. So in 2021, I would argue that, again, you want to confirm that pathology is present, do a careful exam, resect all visible lesions, look at the evidence, what you have. We can manage low-grade and high-grade and T1A cancers very well. T1B is really still surgical for the reasons I mentioned, but in a poor surgical candidate who doesn't want, someone who doesn't want surgery, it may not be unreasonable to do certain select sort of SM1s endoscopically, because there is some data showing that they do well long-term as well. So what have we learned in 20 years that I've been doing this? Inspection is critical, but we've really gotten very good at sort of identifying lesions and really making sure we appropriately select patients for endoscopic management. You should resect all visible lesions, flat or otherwise, that you can identify. And then EUS really doesn't have much value in the T stage, but it's really more to look for malignant adenopathy in patients with known or suspected cancer. We like band EMR for the safety advantages. You don't really need to lift in most cases, but if you have a little bit of a depressed lesion, you can. You have to not only get rid of the bumps and the dysplasia, but you also have to get rid of all of the Barrett's as well, and make sure you control the reflux afterwards to maintain the work you've done. And we now have quality metrics.
That was a great summary of endoscopic diagnosis and therapy by Dr. Muthuswamy. He's a real expert in the field. Thank you, Raman. My name's Paul Tosti. I'm a thoracic surgeon here at UCLA, and it's a pleasure to talk to you a little bit about surgical approaches to esophageal cancer patients. So my goals for today are to at least give a high-level overview of these topics, selecting appropriate surgical patients, how we evaluate patients preoperatively, the role of multimodal therapy, which I think Dr. Wainberg and Dr. Radlow have extensively discussed in other separate talks, so I'll just touch on that. And then most of the talk will focus on what the surgical approaches are, and I'll spend some time at the end talking about kind of newer, more minimally invasive approaches. So how are patients identified? And Dr. Muthuswamy went over a lot of this already with his talk. But a tissue diagnosis is established endoscopically. All patients need to be staged with cross-sectional imaging. A PET CT is helpful when it's available, and endoscopic ultrasound again, as discussed. Patients with local regional disease are potential surgical candidates. So patients with metastatic disease to distant organs or distant lymph nodes well outside of the tumor field are not generally considered surgical candidates. And then with local regional cancer, the two big questions are how early is it? Is it an early enough stage that it can be treated endoscopically, or how advanced is it, and does it need neoadjuvant therapy? It's important when considering esophagectomy to do a really thorough preoperative evaluation. It's a large operation with the potential for quite a bit of morbidity. So making sure that patients are properly optimized for surgery is really essential. Most of that focuses on the cardiac and pulmonary systems. Those two categories are where most postoperative complications occur. So we do spend a good bit of time going over patients' medical histories and thinking about whether they need a further workup with things like echocardiogram, stress tests, pulmonary function tests. Most of our patients are older and have a variety of comorbidities, so most of them end up getting most of those tests. The other thing that I think is really important to think about in these patients is their nutritional status. Many patients present with dysphagia and reduced oral intake and are malnourished when they present with cancer. So it's important to address that and try to supplement their nutrition and prepare them for surgery if that's the direction things are heading. And it's not infrequent to need to place a feeding tube preoperatively or even pre-neoadjuvant treatment. It is useful for patients who do need feeding tubes to consult with an esophageal surgeon before placing the tube. Different surgeons have relatively strong feelings about what type of feeding tube should be placed. I'll talk about it in just a moment here, but the stomach is usually used as the conduit to reconstruct after resecting the esophagus. And many esophageal surgeons prefer not to place tubes in the stomach, not to place gastrostomy tubes, but rather to place jejunostomy tubes preoperatively for patients who need feeding. I'll just touch on multimodal therapy. Most of our patients who eventually go to surgery benefit from neoadjuvant therapy. There's a landmark trial called the CROSS trial that really established this approach, and that's a concurrent chemoradiation regimen for patients with local regional esophageal cancer that is either lymph node positive or T3 or greater, and they showed a significant survival benefit. There are also many centers, more commonly in Europe, that are starting to treat particularly adenocarcinoma patients who meet criteria for neoadjuvant therapy with chemotherapy alone rather than chemoradiation. The T1B cancers are still generally treated with surgery alone because of the relatively lower lymph node metastasis risk. You know, a T1B lesion by endoscopic staging with negative nodes is unlikely to have nodal involvement, and those patients typically do well with surgery alone. T2 N0 disease is a bit controversial and institutional specific. Many centers treat T2 patients with surgery up front, but many also advocate for neoadjuvant therapy in those patients. Given the high risk of lymph node involvement in 2T patients, even when they're staged N0 preoperatively, my personal bias is to err on the side of treating them up front because of the well-established benefit in patients at higher stage. The other issue with T2 disease is many patients who are staged as T2 by ultrasound end up having a different T stage at surgery, and that can be earlier or later. But you know, some of the patients that are ultrasound T2 are going to be pathologically T3. So so that's why, you know, some people err on the side of neoadjuvant treatment. Adjuvant therapy is also evolving. Again, the oncologist can speak to this with a lot more authority than I can. But the recent CheckMate trial that came out has now established a role for adjuvant immunotherapy in resected patients with any residual disease. And I think that adjuvant treatment area will continue to expand as we have more effective therapies. So surgical approaches. There are a variety of ways to approach esophageal resection. The most common surgical approaches are transhiatal, Ivor-Lewis, or abdominal and thoracic, or three-field, also known as the McEwen esophagectomy, which is abdominal, thoracic, and a neck incision. Thoracoabdominal is also a described incision, but is a large morbid incision that's not frequently used these days. The general principles of esophageal resection are resection of the cancer with adequate margins of normal tissue, removal of all of the regional lymph nodes for proper staging, preservation of blood supply for the gastric conduit, which will be used to reconstruct the resected esophagus, anastomosis with minimal tension and good blood supply, good drainage in case there is an anastomotic leak postoperatively, which, depending on the series, happens anywhere from 5 to 15% of patients. In modern series, it tends to be lower. And enteral feeding access. Most surgeons place a feeding jejunostomy tube at the time of esophagectomy, although some centers are starting to be selective about So the gastric conduit, with removal of part of the esophagus, the stomach is tubularized, and you can see in this picture how that's done. This is the proximal part of the esophagus has been divided in this operation already. And then here's the GE junction, and a small portion of the stomach is resected in this kind of J-shaped line, which makes the remaining stomach into a more tubular structure, which then can be pulled up into the chest or all the way to the neck for anastomosis. In order to do this, most of the blood supply of the stomach has to be disconnected. The one vessel that is preserved is the right gastroepiploic artery here. So that is an essential component of all esophagectomies, is preserving this artery for the conduit, so that the patient can have a functional conduit that heals well. If the stomach is not usable for anatomic or prior surgical reasons, there are other options. The right or left colon and small intestine can be used, although those are more complicated operations. So quickly go through the main types of esophagectomy. The first is the transhiatal esophagectomy. This is done through an abdominal and left neck approach. The mediastinal dissection is done from the abdomen and the neck. The chest is not directly entered, and the anastomosis is performed in the neck. The advantages are that there are no chest incisions, which may result in less pulmonary morbidity to the patient. It's also more efficient. The patient does not have to be repositioned during the operation, so it can result in a shorter operation, which can be less physiologically demanding for the patient. The potential disadvantages are the lymph node dissection may be inferior, particularly if it's performed blindly from the abdomen and the neck. Mediastinal complications such as bleeding in the mediastinum or airway injuries can be emergent and difficult to deal with when the chest is not accessed. There may be a higher leak rate with neck incisions. Historically, that's the teaching, although with more modern series, the leak rates are probably more similar and lower in both chest and neck incisions. And there is a higher risk of injury to the recurrent nerve and resulting vocal cord paralysis with a neck approach. So this diagram just shows where the incisions are made in the traditional open approach. It's an upper midline laparotomy and a left neck incision. And the majority of the operation is done through the abdomen. The stomach is mobilized, and a good portion of the esophagus is mobilized through the hiatus. And then the upper part of the esophagus is mobilized through the neck. And the esophagus is divided proximally. The stomach is divided distally, as we reviewed previously. And then the stomach is pulled up through the mediastinum into the neck, and an anastomosis is made. The Ivor-Lewis esophagectomy is an abdominal and right chest approach, and the anastomosis is performed in the chest. The advantage of this is that the mediastinal dissection is done under direct visualization with good exposure, and the level of the anastomosis can be adjusted based on tumor anatomy. So if a patient has a distal esophageal cancer that involves or even crosses the GE junction a little bit more, stomach could be resected, and the anastomosis could be performed a little bit lower, and that could be more difficult in an approach where you're trying to do an anastomosis up in the neck, because you have to have enough stomach to reach. The potential disadvantages are that it may be difficult to get a good margin on a mid-esophageal lesion that's higher up in the chest, and it does require chest incisions and the resultant morbidity of that. Here's the diagram of the standard open operation. It started with the laparotomy, and then the patient is turned on their side and a thoracotomy is done, and the thoracic part of the esophageal mobilization and the anastomosis are done in the chest. This is the stomach being mobilized in the abdomen. As I mentioned, the right gastropaploic is preserved, and the other blood vessels, the short gastrics here that go to the stomach are divided, and the left gastric on the other side is divided as well. And then this is the view via a thoracotomy from the chest. So this is the lung being retracted anteriorly. The patient's back is back here. This is the esophagus being lifted up and dissected free with its surrounding lymph nodes. And you get a good view of the airway here and the pericardium, the posterior hilar vessels of the lung. So you really get great visualization of the mediastinal dissection with this approach. The last approach that's commonly used is a three-field esophagectomy, also known as the McCune, and also sometimes crudely referred to as the three-hole esophagectomy. I've never been a big fan of that term. It just doesn't sound very elegant. And this is really a combination of the techniques described in the two prior operations. So it's an abdominal right chest and left neck approach, and the anastomosis is performed in the neck. So the advantage is that you get to do the mediastinal dissection with great exposure as you do in the Ivor-Lewis. You maximize your proximal margin as you do with the transhiatal. And then the disadvantages are those that go with a neck incision with the higher risk of the recurrent nerve injury, and also the potentially a little bit higher leak rate. I will say that the classic teaching is that neck anastomoses leak a little bit more often, but leaks higher up in the neck or mediastinum are typically less morbid to the patient. So it's a balance. And then the last disadvantage, which I didn't list there, is that it has the most incisions, so potentially has some more pain and more morbidity associated with all the incisions. So I'll just touch on some of the possible postoperative complications that can happen after esophagectomy. This is by no means an exhaustive list, but it is some of the more common things that can happen. And my main point here is that this is a really major operation with a pretty high morbidity rate. Somewhere on the order of 40 to 50% of patients will have one of these complications. In the pulmonary category, a pneumonia, particularly aspiration pneumonia, is something that we really look out for and is probably the biggest single risk. Atrial fibrillation is common after esophageal surgery. Other cardiac complications are quite rare, thankfully. Anastomotic leak is something we're always concerned about. Preserving the blood supply to that stomach conduit is essential. And if that fails, it can be catastrophic for the patient. And on very rare occasions, that can result in the conduit necrosing and requiring removal and subsequent later reconstruction. Chylothorax is a rare complication of esophageal surgery. And then longer term things that we face are strictures. We try to do the anastomoses in a way to minimize that. So prevention is key for these postoperative complications, and that goes into the preoperative evaluation and the postoperative care, focusing on pulmonary toilet measures, early ambulation, avoidance of hypotension, and keeping your anastomosis well perfused. The other key is early recognition of these complications when they do happen and aggressive treatment. It's well established that centers that do frequent esophageal resections have better outcomes, and I think a big part of that is not necessarily that they have lower complication rates, although they may, but that they probably have much higher rescue rates. That when complications do happen, they can recognize them and address them appropriately in a timely fashion, and still have a good outcome for the patient. In the last few minutes that I have, I just wanted to talk a little bit about minimally invasive esophagectomy, and hopefully have some time to go over a little bit of video. All of the surgical approaches that we discussed, hiatal, transhiatal, Ivor-Lewis or abdominal thoracic or three-field, can be adapted to minimally invasive surgery with laparoscopic techniques for the abdomen, thoracoscopic techniques for the chest, robotic techniques, which are variations of both laparoscopic and thoracoscopic techniques, And then hybrid operations can be done when indicated. So you may have a midesophageal tumor that's quite bulky that you don't think can be resected with a minimally invasive approach, but you can do the abdominal portion laparoscopically and then do a thoracotomy, or vice versa if the indications are there. So I would say at this point in time, for a vast majority of our patients, there is a role for at least some amount of minimally invasive surgery as part of their esophagectomy. The benefits of this are well established in multiple trials. I didn't include the specific trial data, but all of these things have been shown with pretty good data that there's less overall morbidity with minimally invasive surgery. There's fewer respiratory complications, less pain, lower blood loss, and shorter lengths of stay. And that's true when you compare minimally invasive, completely minimally invasive esophagectomy to open esophagectomy, and when you compare hybrid or partly minimally invasive esophagectomy to fully open esophagectomy. The big question with minimally invasive cancer surgery is it a good cancer operation? And that's pretty well established in the literature as well, that a comparable lymphadenectomy can be performed with minimally invasive techniques, and survival is comparable between groups. I will say that there is still a role for open surgery, even in the minimally invasive era, and it is key to properly select patients to achieve the best possible oncologic outcome. I certainly would never advocate for a minimally invasive approach that compromised in any way as far as adequacy of cancer operation goes. But thankfully, for most patients, we don't have to compromise, and we can use minimally invasive techniques for their operation. Just real quick here on that topic, this is a big propensity match study that compared open esophagectomy, OE, which is the green line, minimally invasive esophagectomy, MIE, the red line, or robot-assisted minimally invasive esophagectomy, or RAMI, the blue line, using the NCDB database. And you can see the curves are the same. So this is just kind of all comers. So you might say, well, the minimally invasive group, maybe they have earlier stages, so maybe they're not all the same. So they propensity matched the different groups, and the curves are still the same. So even when you take patients that are stage matched and comorbidity matched, the approach is not really what determines their survival, but it can have a significant impact on their postoperative morbidity. And then I just wanted to go over.
So we're going to stop here. Link is there if you want to just see the rest of it. So today we had a chance to look at two pathologies. So we looked at nasopharyngeal cancer, and we looked at esophageal cancer. So both of these are basically in upper jaw, with esophageal cancer also traversing down to the middle jaw through diaphragm. So next week we're going to look at breast cancer and lung cancer in our fourth lecture. So this is, of course, going to be all recorded. You can access it through our academic office and our AMP educator. Thank you all for being a part of the course, and I'm looking forward to see you next week.